second, third, and I think fourth also. So they'll tell exactly what views means from a neonatologist perspective. We're not really getting into the cardiology point of view. So, and then we'll be having some common topics. So there are three common topics which you keep on encountering in your practice. So one is PDA, and another one actually is pulmonary arterial hypertension, and there is one talk actually on some transitional circulation, what happens after birth in the first 24 to 48 hours, how things change. That's one set of talks are going to be there. So keep it interactive. So don't hesitate to stop at any point. While the talk is going on, you can stop Dr. Ankur, any of us, happy to answer you. So whatever we know, we can share with you. But one actually basic premise actually is that this workshop is to sensitize you what exactly a bedside echo means. We don't actually intend to make you an expert overnight in echocardiography. So you challenge your cardiology person that I can do everything what under the sun. And that's not the idea. So to sensitize you, to make you understand what exactly it means, what we intend to do, what we're supposed to do, and how to use a tool actually in the bedside. That's the idea. So we are focusing more on a functional aspect of the heart, not structural heart disease. So even though as a part of a demo and your talks, we'll talk about actually structural heart disease and different views also. Like so find something is not normal in a structure, you can call the cardiology person and tell them something I didn't find doesn't look right. So you can do that part. So you cannot certify, but you can screen. So focus on screening the structural heart disease, and we'll second focus on cardiac functions and various morbidities which we commonly see and how to apply that. That's the idea. So keep it interactive, don't hesitate, stop us where you don't understand from the basics, and we keep moving ahead. So Dr. Ankur.
Relevant in our scenario to know the basics, because as they say now, basics is the foundation of anything. So sir and everybody is there to take care of the major things, our views, our finding out the congenital disease initially and then taking it further. But what are the basic principles of the ultrasound? I will take a slide through that in the next 20-25 minutes, and we'll try to finish it off in that time. So I'm Dr. Ankur. I'm from Cloud9 Hospital, Whitefield, Bangalore here. Next slide, please. Next slide. So as we know, what is ultrasound? Ultrasound is anything which is actually a sound wave, as you and me are talking to each other. Our wavelength is in the range of, or our frequency is in the range of 20 hertz to 20,000 hertz. Any sound more than that is an ultrasound. Any sound less than that frequency is an infrasonic. So this is the basic of the ultrasound which we are going to discuss today, that what we are going to concentrate. So sound travels as a magnetic longitudinal wave in which back and forth particle motion is parallel to the direction of wave travel. Ultrasound is a high frequency sound with frequency more than 20, means 20,000 hertz. So this is nothing new. We are using this technology or this concept from 1800s, and now over a period of time we have evolved a lot, and now we are able to do called as echolation, where these animals either talk in the sounds less than 20 hertz or more than 20,000 hertz, and they communicate, they locate their prey, they hunt accordingly by the sound waves they emit and by the sound waves they get back to them in order to assess what is the difference, how far is the prey, how we have to reach over there. They communicate among themselves by these sound waves. So this is always there in our ecosystem, but we are using this for our purpose from 1800. So this is a brief history of the echo or ultrasound, I said. So ultrasound is a very important thing. So physiologist Lazzaro Spalzi was the first to study echolation among bats, and which forms the basics of the ultrasound physics. The most important work was done by the Pierre and Jacques Curie, who discovered piezoelectricity, which I will discuss now, what is the piezoelectric material and the things which help us to get the ultrasound waves. And ultrasound transducers emit and receive these waves. So all these things were done. In the Second World War, a lot of work was done on the ultrasound for helping, not for diagnosis or anything, for the treatment purpose, for the more of it was therapeutic use of echo, which was done during the Second World War times, and from there it picked up as the device to do various type of therapeutic and diagnostic interventions. Next. So this was our Eder and Hertz echocardiographic trace of the anterior mitral wall in the 1950s. So that was the type of the ultrasound machine which used to be there in those times, and we used to get these type of waves. That time we were mainly using A mode. We will talk on those things a little bit. So that's how it actually developed over a period of time. So once we start about the ultrasound, the basic of the ultrasound I need you to understand, and most of you must be knowing, piezoelectric effect. So what we are doing in the piezoelectric effect, the most important component of the machine is the transducer or the probes. The probes has the piezoelectric material which generates the piezoelectric waves. Now what happens is that a transducer is the most important thing in the machine. When you put a signal, electric signal to the transducer, the material inside the probe, the piezoelectric material inside the probe starts vibrating at a very high vibrations. This vibration, convergence of electric energy into mechanical energy and emitting the sound waves is the effect of that material. This sound effect will be emitted, ultrasound waves will be generated. This will go to the medium, our tissue, anything, whatever we are putting to use to. They will get reflected from the various surfaces in the body at different levels, come back in the same mechanical energy form, hit back to the piezoelectric material, get converted into the electrical, and is reflected on our screen. The piezoelectric material is first electrical energy is converted into mechanical energy is getting converted into the sound energy, piercing the various tissues of the body, reflecting back at the various levels of the body or tissues, coming back in the form of mechanical vibrations again in this piezoelectric material, and then again converting into electrical energy to be seen on the machine. So this is the whole or the base of the ultrasound. Ultrasound waves can be generated by material with a piezoelectric effect. The piezoelectric effect is a phenomena exhibited by the generation of electric charge in response to a mechanical force or applied on certain materials. Conversely, mechanical deformation can also be produced with an electric field is applied to such a material, also known as piezoelectric effect. So first we are deforming it, producing the mechanical energy, and then this mechanical energy at the time of receiving the images again gets converted into the electrical energy. So this is how the system works, the material works. Now we are coming to the most important part of the ultrasound physics. When we talk about the most important part of the ultrasound physics, we have to know that this is everything. Now we have to understand the ultrasound or any sound wave in the form of a music system. Let's say a music system is lying over here, or this is the music system. Now when I'm speaking, there will be compression of the waves happening in the environment. So there will be wave generation continuously happening. So the area where the waves will get clumped up is the area of compression, and the area where it will get far, it will be area of rarefaction. So this generation of waves in the system, whenever we talk or whenever an ultrasound sound is emitted, is the whole concept of this ultrasound machine. So as the speaker is emitting sound, there will be areas of compression, there will be areas of vacuum, that is rarefaction, again areas of compression. This is how the waves are generated. Now when I tell you, now there are some terminologies given to these waves. The amount of the wave going above the baseline, the signal going above the baseline is called as the amplitude of the wave, or the complete, whatever we have got from top to bottom, from plus to minus, the amount of the displacement which has happened. Now in between the two areas, when we see in between the two areas of compression, the area where we are seeing the compression, that is known as our wavelength. That is the difference between the two compression, two troughs. So that is the wavelength. And the amount of the waves, the number of times the waves is passing through a particular point is called as frequency. Means if the frequency is more, the amount of the waves or the wavelengths will be passing will be more. And if the amount of the, if the, yeah, so if the amount of the, if the amount of the wavelength which will be passing through a particular point is more, then the frequency is more. And if the wavelength passing through a particular point is less, the frequency is less. So we'll work on that, but we have to know that wavelength is the distance between the two area of compressions. Amplitude is the total amount of the distance which we have created from top to bottom. So amplitude is the maximal compression of the particles above this baseline and is described in the terms of decibels. Now amplitude is described in the terms of decibels. Why it is described in the terms of decibels? It is a conversion factor. What happens is that there are many types of the waves which are generated. So some will have very low amplitude, some will have very high amplitude. Amplitude again will depend on from where the rays are reflecting back from the tissue. So in order to know that, there will be certain areas where the amplitude will be very low and there will be certain areas where the amplitude will be very high. So in order to put all the picture in one frame, they are described in the terms of decibels and they are converted into the decibels, so that the conversion factor is made such we can see all the types of amplitude waves which are generated from the body or from different tissues on one plane. So the wave amplitude can be very, very different, can be very high, it can be very low, but they are converted into decibels so that we can get the picture of each amplitude of the wave on our machine. So amplitude equates to the loudness of the sound wave. It is the changes in the amplitude that produces the gray or 2D echographic images. So amplitude is such important because these are the sound waves which are going to be generated from the back and forth motion when we hit the tissue. So advantages of using the decibel scale are that a very large range can be compressed into some smaller number of values that with low amplitude and signals to the displayed alongside with the high amplitude. So that is the function of the converting into a decibel, where it can be represented in one plane. Next. Now intensity, how we will see the images, the brightness, the intensity of the images will be directly proportional to the amplitude. So it is the square of the amplitude. The images, the brightness we are getting about the from the images is directly proportional to the amplitude square. So that's why the amplitude is so important, and that's why it is compressed in such a way that the amplitudes of all the waves generated, we will get it. Now, as I told you, wavelength. Wavelength refers to the distance between the two adjacent area of maximal compression, which we were seeing is the wavelength. The distance between the two areas is the wavelength. The number of the wavelengths per unit time means how many wavelengths will pass in the per unit time is the frequency, which is the most important thing, because we were doing the ultrasound with the help of the transducer, which have a definite mention of the frequency in each probe. Frequency may be expressed as cycles per second, also called as hertz. Next. Now, what will be the propagation velocity? Means how however the sound will travel, the velocity of that is equal to the propagation velocity of the wave expressed by the formula. So propagation velocity is frequency into wavelength. Anything how fast it will travel will be dependent on how many wavelengths are there and how much time it is taking per unit time to cross one wavelength. So the propagation velocity is frequency into wavelength. Frequency into wavelength. Yes. Next. Now, like this. This is a very important relation. Now the propagation velocity is constant in all the tissues to a most level. Especially if we talk about the heart, it is somewhere in the range of 1.54 into 10 raised to the power 3 meters per second. Now if our propagation velocity is fixed for any of the material, it becomes a constant value. So now if it is a constant value, we have got the clear-cut idea that our wavelength is inversely proportional to the frequency. This is very important. This is the most important relation we have to understand. Why? A low wavelength sound will go deep. If you are very far from a concert area, you have seen any concert area, what you will see at the very far, when you are just 2 kilometers away from the concert or 1 kilometer away, you will hear the bass, doom, doom, doom sound. Correct? What is that? That is a low wavelength
sound which you are getting. So the low wavelength sound will have the ability to travel long distance into the tissue. And frequency, when you will go near to a concert area, you will be able to differentiate all types of sound. Beautiful guitar sound, then violin sound, all the sounds you will be able to differentiate clearly. Now the frequency of those sounds are high. That's why when you go near to the concert area or you are in the concert, you will be able to make up all the sounds. But when you are very far, you are only listening bass. So the wavelength of those sounds which will be low will travel far, but then frequency will automatically become low. If the frequency is high, wavelength will be low. So that's the most important relationship. If we are making the frequency very high, we will not be able to see the very deep structure. And if our frequency will be low, then wavelength will be high and we will be able to see the deep structure. So that's how the importance of the frequency and wavelength is important to you to select the probe to find the what images you want. Now as a thumb rule, in neonate, we don't want a very high wavelength because our neonate is very okay, it's very small. So when we consider about the NICU echos, neonatal echos, we don't want a probe which has a very low frequency. We want a probe which has a high frequency because wavelength is not much of a concern here. So as a rule, we use the frequencies which are high for the neonatal echos. Now, this is the third important thing, resolution. So what is resolution? The clarity of the image. Resolution as our megapixel of our cameras, that how beautiful our image will come. So that is the resolution. So resolution is the ability to distinguish 2 points in space, and it is determined by the wavelength. So the longer the wavelength, the lower the resolution and greater the tissue penetration, what I told you. It is related to the wavelength, but it is inversely proportional to the wavelength. जितना ज़्यादा फ्रीक्वेंसी होगा उतना क्लियर इमेज आएगा, उतना अच्छा इमेज आएगा. जितना ज़्यादा हर्ट्ज बढ़ता जाएगा, 12 मेगापिक्सल, 14 मेगापिक्सल, 20 मेगापिक्सल, जितना ज़्यादा हमारा फ्रीक्वेंसी बढ़ रहा है पिक्सल का कि हम कितना तेज कैप्चर कर सकेंगे, उतना तेज जो है हमारा इमेज क्लैरिटी ज़्यादा होता जाएगा. पर हम बहुत डीप नहीं देख पाएंगे, हम बहुत डीप नहीं जा पाएंगे. इसीलिए जब हमें कोई बहुत डिस्टेंस की फोटो लेनी होती है तो हमारा शटर टाइम कम हो जाता है. हम शटर टाइम को कम कर देते हैं जिससे कि हम बहुत ज़्यादा इमेज को गैदर कर सकें, क्योंकि हम वेवलेंथ ज़्यादा छोड़ना चाहते हैं. So that's what, the longer the wavelength, the lower the resolution and the greater the tissue penetration, and it is the changes in frequency that form the basis of the Doppler echocardiography. In ultrasound imaging, there are two aspects of spatial resolution, axial and lateral. There are two types of resolution which we are looking into. One is the axial resolution, is the minimum separation of above and below planes along the beam axis. It is determined by the spatial pulse length, which is equal to the product of wavelength and number of cycles within a pulse. Axial resolution is equal to wavelength into the number of cycles per pulse, means it is the frequency. Next. Now lateral resolution is the another parameter of sharpness to describe the minimum side-by-side distance between the two objects. It is determined by both ultrasound frequency and beam width. The higher the frequencies have narrower focus and provide better axial and lateral resolution. So the concept is the frequency is high, overall your images will be better, but it will not be going deep inside the tissue. Next. Now I'm coming to the another important aspect. The interaction of the ultrasound with the tissue. Whenever we are sending the ultrasound or we are putting a probe on the baby, what is going to happen exactly is the interaction of the ultrasound with the tissue. So as the ultrasound travels through tissues, it is subject to number of interactions. The most important features are as follows. Now I'll show you this image. If you see that, you have to understand only one thing. Ideally, anything falling on any object should be going back to this object with the same angle. But it never happens because there will be something which will be going down. So there will be the loss of energy. So the angle of incidence is not always equal to the angle of reflection. But if you have a thing which is like if I'm traveling to, there is a, I'm talking now from here. So there is only this, they have put this covers. So actually it is mostly air. So this is the same density. So from here to there also my sound will go. It will not get reflected back. Second thing is that if there is something which can completely reflect it back, like if you put a glass and the sunbeams are coming, it will completely get reflected back. It will not be going anything inside. So what happens is that if anything which has this is called as impedance. Impedance means the difference in the density of the two substances which will allow the rays to get reflected more or refracted more. So ideally angle of incidence should be equal to angle of reflection, but never happens, and there will be some area of transmission angle which will be going deep inside the tissue. Now this is what we call as a area of refraction. So before understanding, I told you acoustic impedance. Acoustic impedance is the process of sound traveling through a medium. It is defined by the density of the medium times the velocity of the sound that travels through that medium. As sound passes through a homogeneous substance, it travels in a linear fashion. If it is traveling through this air only, it will travel in a linear fashion. It will not get refracted anywhere. However, when the sound wave reaches an interface between the two tissues which different densities, anything, if it is water, it is tissue substance or anything, then part of the sound beam is reflected back to the source and part of the sound beam will go inside the tissue. The amount of reflection is dependent upon the difference in the acoustic impedance of the two tissues. Acoustic impedance presented as Z, which is equal to the density into velocity. More the difference in the acoustic impedance of the two materials will be there, two mediums will be there, more our energy will be, more our penetration will be there. If it is of the same acoustic or lot of difference of the acoustic impedance is there, means this is very high, the area below where the image has to go is very high density, then it will not go only, it will not travel only. But if the difference is such that it is high and low, then it will definitely travel. Reflection, I told you, refraction, a change in the sound direction with crossing the boundary between the two medium is called as refraction. If the propagation speed through the second medium is slower than that through the first medium, the refraction angle is smaller than the incident angle. So the amount of the angle which will be made, as we assume that the beam is happening like this, it will immediately make the same angle, it will not make the same angle. It will get refracted, and because the medium of the sound is slow, so this angle will be narrow and as compared to the angle which we are expecting, perpendicular. So these changes in the ultrasound beam direction by refraction can lead to the formation of imaging artifacts. So again, it depends that how we are keeping the probe. हमारे probe जितना ज़्यादा, more and more our probe is tilted and all, more and more refraction will happen. More and more refraction will happen, more and more artifacts can happen. More and more our probe is perpendicular, more the beam will go straight, more nicely we can see the things. But again, we will have to make a choice as per the image we want to get for the baby. Scattering is a type of reflection that occurs when ultrasound waves strike small or irregularly shaped objects, such as when the images are going out inside, some red blood cells are there inside, like vessel is there, so scattering will happen. So ultimately, again, we are not getting the gain out of it. So these are some of the things which we have to keep in the mind. Again, attenuation is the loss of ultrasound wave. It travels through tissues. It is the loss of intensity and amplitude. It is directly related to the distance of wave front travels. Absorption occurs when the ultrasound wave energy is converted into another energy form, such as mechanical vibrations and so on. Now I would like to come on the modes. So what we have discussed is what is ultrasound, what is the piezoelectric effect, how it is generated. Third thing we have discussed about what is the different types of angles, wavelength and frequency combination, which is very important for us to understand which probe we have to choose, how we have to go ahead. When we want the deep penetration, we have to look for the wavelengths high. When we want the more clearer images, we have to look for more frequency high. So these things we have got it now. Now we will discuss about the different modes. As such, there are many modes on the machine, but I tell you there are only 2 or 3 important modes which we should know about. First is A mode, which is obsolete now, which was earlier used where only a single beam of the sound wave was getting, and we were getting to know the images out of it. It was the amplitude driven. No real-time echocardiography was happening. We cannot see the movement of the structures at that time. We cannot see the 2D picture of those images at that time. So we realized that that was the A mode. Then came the B mode. B mode is the most widely used mode currently on your machine, which is there written over there, and you get 2D echographic images from that. M mode is the motion mode. Again, in order to see the motion happening, especially through the any area, through any vessels, we put this M mode. M mode has the basic thing is that M mode is widely used in the cardiac ultrasounds to know the flow of the blood in the various mediums or through the various channels. M mode is not widely used by the ultrasonologist in various other places. Only for knowing the pattern we do use it. And the last one is the Doppler. So Doppler is again an important thing. We know that the Doppler studies we have to do for many number of time to know our values of various things. So how much is the amount of regurgitation, how much is the mitral regurgitation, or how much is our pulmonary pressures, for everything to calculate, for how much is our ejection fraction. To calculate everything, we have to put on the Doppler images. Next. So the B mode is a two-dimensional image of that area that is simultaneously scanned by a linear array of 100 to 300 piezoelectric elements rather than a single ones which was there in the A mode. So A mode and B mode, that is the main difference. The amplitude of the echo from a series of A scan is converted into dots of different brightness in B mode. Because so much piezoelectric signals are going or effect is generated, we are getting a combined image of 200 or 300 signals, getting a 2D image of any structure what we want to see. This is the M mode when we put to know the how is the motion happening at any wall motion, and our regional motion. So all the motions for all those things we put the M mode. It is a one-dimension mode, temporal tracking during cardiac cycle. Multiple A mode images are created and represented over time, demonstrating movement or reflectors with time. Images are getting uploaded at the rate of 1000 per second. Great quantitative imaging. Disadvantages are that no global info, tunnel vision, accurate cursor position is must to know the M mode. If you are not putting the accurate cursor motion, you will not get the proper images. Next. Doppler study, as I was telling, Doppler is again a beautiful thing, which was effective like any ambulance, any car coming to you. As it is coming, you will hear the sound coming very far, and as it goes off, you will understand that the sound is going off from you. So this only technique was first used by the Australian physicist Johann Christian Doppler. The term describes a change in the frequency of wavelength of sound wave resulting from relative motion between the sound source and the sound receiver. So the sound source means the beam where it will strike the thing which or any blood vessels or any the blood which is flowing, and how it is coming back. So if it is coming from far, it is coming towards you, you will see that the images is coming towards you. If it is going away from you, you will feel that this is the going away from the transducer or from where it is receiving the signal. So this is the concept. When a sound source moves away from the receiver, the received sound has a low pitch, and vice versa. So low pitch and high pitch, again amplitude, it will describe the Doppler images. If the sound moves towards the sound receiver, the sound waves have to be squeezed and a high pitched sound occurs. If the sound source moves away from the receiver, the sound waves have to be stretched. The wavelength becomes more and the received sound has a lower pitch. The magnitude of the Doppler shift depends on the incident angle between the direction of the emitted ultrasound beam and moving reflectors. With a 90-degree angle, there is no Doppler shift. That is also very, very important. If you have a radial artery here, you put a transducer or you put a probe here exactly at 90 degree to it, you are not going to get anything because it is just flowing below you. When you are going to tilt it a little bit, then you will start getting the Doppler images where if it is traveling towards you, you will get red in color. It is traveling away from you. If you will do like this, it is traveling away from you, you will get the blue color, which is the convention color. So that also is very, very important, that what angle you are keeping for the transducer for the images to be coming to you. Next. Color Doppler produces a color-coded map of Doppler shifts superimposed onto a beam mode ultrasound imaging. Blood flow direction depends on whether the motion is toward or away. Selected by convention, the red color is moving towards the probe, the blue color is moving away from the probes, but nowadays the machine has all the facilities So in fact, you can change that also. You can make it blue coming towards you and red going away from you. But by convention, it is red coming and blue going. Now the last part of it. When we get this is color mapping, what we discussed now. This is the color. When we just put color button on your machine, you will start getting these colors on your machine, red, blue and all. Now when you have to take the significance out of it, or the quantitative assessment out of it, you use pulse wave Doppler or continuous wave Doppler. So there are two different types of Doppler which is available, pulse wave and continuous wave, which we will discuss it again in the further scenarios, how we will go ahead with this continuous and pulse wave Doppler. The main concept, or again the physics behind it, is pulse wave Doppler is mainly used to get a pinpoint values, because it will be a single image or single wave which will be traveling, and it will have a limited velocity, and it will try to take out the value from a certain specific area where you want it. Whereas the name suggests the continuous wave Doppler, it will be the continuous burst of the sound waves which will be going on. It will be high velocity, and you will get along the entire length of that sound traveling, you will get the values. So the pulse wave Doppler is placed to an area where we want to know exact values at a particular area, rather than continuous wave Doppler where you get continuous sequencing. Pulse wave Doppler is up to 5 times more sensitive in detecting blood flow than color Doppler. It is less dependent on the scanning angle. Thus, pulse wave Doppler can be used to identify the smaller blood vessels more reliably. The drawback is that the Doppler does not provide any information on the direction and speed of blood flow. So it will not be able to see that which direction it is traveling and what is the direction of the blood flow and the speed. We'll discuss all this in the practical sessions. It will be much more clear. The last part I want to go ahead with very fast is the choosing the probe. So probes, we have mainly two types. Mainly one is the linear probe and one is the arc shaped curvilinear probe. So linear probe will send all the signals together from top to bottom. The curvilinear probe will have arc shaped image where you will get the side angles also. The most important thing we have to understand in the wave, as a new people, when we start doing the echo, the area which is very near to the probe will be depicted on the top of it, and the area far will be depicted long. Most of the times what happens is that we are putting a probe here. Sometimes when we are putting a probe here in our subcostal view, we are seeing the 4-chamber view, and we are seeing that we think that because we have put it here, we will see the atrium above and ventricles down. No, it is the ventricles which you will be seeing at the top and the atrium down, because you are putting the probe here. So the images received from the first point will be reflected at the top, and the images received from the far point will be reflected at the down part. So always you have to remember that which images you are seeing. You are putting the probe like that, you will not see the heart in the atrium and ventricle fashion. It is the ventricle and the atrium fashion. So these are the very important things. In the plaques view, parasternal long axis view also, when we are putting the probe here, the first part you will see that you will think that you will be seeing here. No, first part is your right ventricle. So you will see your right ventricle here, and then your left atrium and left ventricle below. So always keep that in your mind, that which is the part where the probe is near to, and that image will come on the top, and the later images will come down. And again, the direction of the probe will be dependent on that marker. Fine. This is again a phased array probe, mainly used for our ultrasound of the cardiac ultrasounds, where we want from the single point of emission, we want to send the images and get back to it. So again, tips to get good images: which probe you have to choose, what you want to scan, how far you want to go ahead. The last 3 points I will be taking in the last 3 points. Now there is something called as time gain compensation. You must have seen this on your machine. You understand this? So time gain compensation, color, correct, brightness, correct. So time gain compensation is the amount of the image deep inside will take back. They will not be coming in the same fashion as the images from the top will be coming. So you have to give more gain to the images coming from the depth area, from the down area, in order for all the uniformity of the images seen on the screen. So the time gain compensation means the gain you are putting, the the clarity, the resolution you are getting better in order to put all the images on the same front. So this is the time gain compensation. Ideally, always your time gain compensation should be like this, in order to get a good images, where you don't have to give so much gain to the images coming from the top, and you have to give gain to the images coming from the down. Focusing is again a good parameter. So what we do in focusing, we want to focus something, we want to see something. So we make the probe to focus on at a certain depth, which we can quantify again on our screen, so that we can get the clearer picture from that place or that image which you want to see. So when we focus any image, the transducer will try to focus all the beams over there to get the most clarity of the images there. But again, that structure deeper to that focus will again be blurred, because you have focused all your images there. So that is again, you have to keep in the mind, the images below that focus will be very blurred. So this is how the focusing of the different transducer, the round one and the linear one, will do when you try to focus it. Next. And the last part of my talk, as such, the ultrasound is the most safe and efficacious way of finding or doing anything and finding the problems. But still, as we know, it is also used in the therapeutic interventions. It is prone to cause heat more in the body and over a long period of time. But still, the in vitro and in vivo studies have not shown any problem to the ultrasound till now in various studies done. But we will have to keep in the mind that unnecessarily we should not do anything, and whatever time is required, we should try to finish it off everything and come out of it. Thank you. Thank you.
Very good talk by Dr. Ankur. How many of you are good in physics? That is, I am not good in physics. So basically, to summarize, as a bedside ultrasonographer, ultrasonographic neonatologist, you understand only few terminologies. One is resolution, very important. And as told very clearly, resolution means a good picture quality. You want to resolve something more clear, more finer aspect. So higher resolution needs higher frequency. So the number what is in the probe, no, some hertz, Hz or megahertz, higher the number, higher frequency. But higher frequency would lead to a shorter wavelength. So deeper things needs a longer wavelength to reach that. But newborn heart is very superficial. So 7, 10, 12 megahertz frequency, higher frequency would do good for us, fortunately. Newborn heart is very superficial. We don't need actually deep penetration. So we can work with higher frequency. You get a good image. Compare adult actually image and newborn image. You can see that newborn heart looks very crispy and very clear comparatively. That's one thing you should always remember. Take home message number one. And number two, when talk about Doppler, there is one is PW, pulse Doppler. Second is CW, continuous wave Doppler. When there is a high velocity flow in the velocity is very high, means more than 1.5, 2 meters per second high velocity, typically happens in artery flow, very typical in aortic flow. Aorta, pulmonary artery has a high velocity flow. So when the flow velocity goes beyond 1.5 meters per second, you may end up in something called as aliasing. If you do with the pulse Doppler, what will happen is the pulse wave has actually a very focused area of imaging. In a small box, in a rectangle, it tries to capture the red cell movements and direction, and from the movement it gets a velocity. So it doesn't actually really bother what happens outside the box. So since the red cells starts moving very fast, it may end up missing some red cells also. And it will think as if that the movement is happening in the reverse direction. A simple example is rotating wheel example. We all seen your kid, when the wheel starts rotating, cycle wheel or your normal drum, it keeps rotating. At some speed, the direction looks as if changing. Aisa घूम रहा है. Beyond the speed, we get a visual impression. It's illusion basically. The illusion happens that the whole thing now it's reversed. The same thing happens with Doppler only. Velocity beyond a point, then always choose CW, continuous wave. It is less specific, more sensitive, high velocity flows, CW, but otherwise PW is a choice. First do PW pulse Doppler. You could see aliasing, velocity is high, then move to continuous wave Doppler. Those are two take home important things from this talk from my side. Any questions to Dr. Ankur? Anything you can ask? Any doubts in your mind about physics or see, basically resolution, what you talk is axial resolution. If you say only resolution is axial resolution, what does it mean? Along the axis. Ultrasound probe is here, like same, you see it's a probe. So the probe puts a beam like this, the ultrasound beam. You have crystals arranged like this. All the crystal fire the ultrasound beam. So the whole beam comes like a sheet like this. So anything lying actually along the axis, your two objects, like say two red blood cells, for example, they're moving in the artery, in a blood vessel. One RBC is here at any given point in time, and another RBC is there in another location, but both are along the axis. So I want to identify these both RBCs as two separate RBCs. Otherwise, I'll underestimate the velocity. Because I will identify only one RBC, it means that my ultrasound beam goes, hits a RBC, it will reflect back the image, it will come back to the machine. So when another beam is going, the second RBC has passed away. So out of 10 RBC, I capture only 5 RBCs. So I underestimate the velocity, right? So identifying two objects as two separate objects along the axis is called axial resolution. Lateral actually depends on something called beam width. How wide a beam is. A wider beam would end up capturing two separate objects. They are actually found laterally to each other. That's a lateral resolution. But when you say resolution means axial resolution. Plane resolution when I say is axial resolution. That's a very important thing. There is something called temporal resolution. Temporal resolution, temporal means time. Things happening in time. Resolving actually event happened 1 second earlier as separate from 1 second later. It's very important for Doppler principle. Use simple example, no, in all your we read in our old physics, no, you are in a moving train, you are moving, and stationary object is there. There are a lot of trees are there, and you are moving in a bus or a train, and you have a camera with you. Keep capturing. So what will happen? It all depends on the shutter speed. Old cameras, the whole coconut trees there or some banyan trees there, you are moving in a bus, all look smudged. You will not see that trees are individual trees. More recent cameras have a higher shutter speed. It means they can close and open very fast. So they can actually identify every tree as separate tree while you are moving. Either I am moving or the tree is moving or both are moving. So there comes the temporal resolution is important. Temporality means something happening actually in time. Something happened early and something happened later. Temporality. So temporal resolution is another resolution important actually for the Doppler actual principle. So your actually ultrasound machines, recent machines have a very high temporal resolution. So what will happen is even high velocity flows, some AV malformation is happening. A lot of blood actually is moving inside with high velocity in the malformation inside. All AV malformations, angiomas, high velocity flows there. All the current machines actually can pick up the arterial component, venous component, capillary component all separately. And all can be seen very nicely as a mosaic pattern because of the high resolution, high temporal resolution probes which you use nowadays in current ultrasound machines. That's the resolution part. Any more doubt in this? Resolution, wavelength, Doppler. M mode is another important mode which we had to cover a little fast because of shortage of time. M mode is called motion mode, otherwise called easily to understand is measurement mode. You try to make all the measurements in M mode. If possible, all measurements in M mode. The reason actually is for measuring two distances, like say artery, aorta, and I want to go diameter of aorta, and I should look at the aortic annulus where the valve is getting inserted. That's the point I should look at the aortic diameter. So the annulus actually is one aortic wall and other side is another aortic wall. Both are two different objects. From the ultrasound machine point of view, two different objects. If these two different objects are like this, I have aorta running like this. Imagine aorta is like this. Ultrasound probe is coming like this on the beam, on the top. The whole thing is like this, like a sector. Now beam is coming on top. It is going to hit the first wall, close to the probe first, get the reflection back. Another beam comes, hits second wall, get the reflection back. With a good axial resolution, the machine will correctly identify that where the anterior wall is located, where the other wall is located. It gives the distance very clearly in that, right? If the same two are like this, my probe is like this, and aorta is in this direction. So there is one wall is here, another wall is here. Now axial resolution whole principle you're defeating, because both are not along the axis, both are across the axis. Is it clear or not? Beam is coming like this. In the earlier example, aorta was like this, horizontally. Beam is from this direction, hitting perpendicularly. One wall is here, another wall is here. Wall means what actually? There's a blood inside and tissue is a wall. There is a contrast. The tissue is a denser, harder structure, is going to reflect the ultrasound beam better. Blood is there inside, it will not reflect that better. No, it allows the beam to pass on through that. So it look dark. Tissue is actually thicker, more dense, it reflect back, looks more bright. So the wall is a tissue and blood is there inside, it will allow the beam to pass, it look dark. There is another wall now, the other end of the wall, again tissue looks bright. So the both bright ends actually are looking bright because they are reflecting back to the ultrasound machine. So these both objects are reflecting structures, they are along the beam. So here what is operating? Axial resolution operating. That is okay with the temporal. So they are static things, no? Your diameter is not, your aorta is not moving by itself. Blood is moving inside. So something is moving fast, the temporal thing comes inside. Something static, like diameter of a structure, which doesn't move, so your axial resolution plays an important role. Now if I actually do another view, some other view, I get aorta like this. My beam is coming from top. So aorta is aligned towards the beam. It is good actually for the aortic flow velocity, because blood movement is now towards the probe or away, straight line. But to look at the diameter, it's not a good one, because both the points are now lying side by side. So it no more actually depends on the axial resolution. So you will not get actually the real measurement. It means that you will find the object in some location, it might be few millimeters away from the actual location also. So you can underestimate or overestimate the diameter. So for this reason, always for measuring distances, use M mode, and make it a point actually that your M mode scan line should be cutting the structure perpendicularly. So when you do the station, we will demonstrate a M mode scan line should be cutting perpendicular to the structure. Aorta is running like this, M mode scan line should come perpendicularly. If it's coming at an angle, you may not really get the measurements appropriately. So that's the reason M mode is, motion mode is fine, but take home important is measurement mode. M mode is for measurement. That's important.
The views. So we all need to know the views. What are the specific windows? And there are standardized views. So before this, whenever you are kind of starting, when you start doing echo, you have to try to get over time kind of a three-dimensional assessment of the heart. So these are different windows, just like the heart you're looking at from different places, and you need to know how to visualize the heart. So never mug it up. So whenever we started learning, there is a learning curve. Please understand that. So if you are new, if you have already started doing it, you know that there is a learning curve with echo. It's not a one-day workshop, will not teach you everything. So you have to go home, you have to start touching the probe and start doing. Over time, keep attending workshops, you will learn. That's how we have all learned. So please understand that, and please try to understand how the heart looks, so then you will get a hang of how things work here. So we have different views. So one of them, I'm going to talk about the apical and the subcostal views. So from each view, we get a lot of information. So we'll have to look at the basic echo. This is a basic echo workshop. What basic information we get? So one disclaimer is that, again, please, after doing functional echo, please don't consider yourself experts. So when we need a structural echo, I think many people have emphasized that, please call a cardiologist. So here we are looking at functional echo. So functional echo or targeted echo, basically, it answers specific questions. You can do serial assessment and you can do point of care assessment. This is the basic what we are looking at. So there are different views. So there are a set of 3 views which are perpendicular to each other. So if you think of a capsicum, okay. So a capsicum is there. When you cut the capsicum longitudinally, that is called the parasternal long axis. So you cut I think my colleagues will be speaking about each view, but I'm just giving an introduction. So long axis is when you cut it longitudinally. At the base of the capsicum, at the top, you cut it, that is the parasternal short axis. Now you cut the capsicum like this, you take a slice through it, that is the apical view that we are going to talk about, where you see all the 4 chambers of the heart. Then there are the suprasternal windows, then there is the subcostal window. So we'll go one by one. So we'll start talking about the apical view. So this is the classic apical 4-chamber view. Where do you get it? So you get it at the apex. You know the apex of the heart, the cardiac apex. We have learnt in medicine, no? Like how to palpate the apex. The maximum pulsation here. So there you keep it, and there is an angle. So there is, that each probe has a marker. So the marker should be facing the left shoulder. So you keep it at an angle facing the left shoulder. So that you get the classic apical 4-chamber view. So there is a lot of information that can be gauged from this. So we'll look at it one by one. Now, what are the initial impression? What are the things? You can go from outside to inside. What information do you get? What is the sac of the heart? What is it? The pericardium, yes. So you can see fluid here, just in case you are looking at it systematically from outside, you can see a pericardial effusion. So what happens outside? So outside you will see a echo-free space. So, and you can see the effusion just outside that. So these are the chambers, we have marked it there. So typically what happens when a cardiologist is doing it, they will do it the other way. The heart will be inverted. But we have always trained, I would suggest it is easier because it makes anatomical sense and intuitive sense to invert the image. So when we are doing the echo, you will see it inverted. So I usually invert the image up or down so that you see the heart standing up like this. So like how the heart looks. So it is easier for us to comprehend, especially when you are learning initially. So this is the left side on the left. The LA is the left atrium. Then there is the left ventricle. You can see the interatrial septum, that is IAS. Then there is the interventricular septum. Then there is the right atrium. You can see RA. You can see the tricuspid valve. And then there is the right ventricle. I hope that is clear. On the top, you can see the pulmonary veins in this. So one word of caution is you don't see all the pulmonary veins in this. But here, you can Doppler whichever vein you see to see the flow. So at least 1 or 2 veins you can see in this view. Any structure for that matter, suppose it's a PDA you are assessing. You are looking for tricuspid regurgitation. You are looking at pulmonary veins. Always make sure you look at a few windows and know, like if you are assessing a line position also, you should know which windows you should see. And you should look at all the windows and then make a decision. So never jump to a decision looking at PDA, you see one image and you say this is a big PDA. No. So you should look at all the images, then at the end of it, sit and think and then make this thing. Similarly, the pulmonary veins. So you can do a Doppler here, you can see at the top the pulmonary veins. Now what is the other information you can gauge for it? One of the most important thing is how to identify the ventricles. This you will see, you are not a cardiologist, you don't need to go into extremely, complex cardiac heart disease, but you should know at least to identify some, abnormal hearts. So how do you identify the hearts? How do you identify the left and the right ventricle? How do you differentiate them? Anyone? So how is the left ventricle shape? So left ventricle is shaped like a bullet. So I have to go fast in the interest of time, so I'll quickly go. So it's shaped like a bullet. It has smooth walls. If you look at it, there are smooth walls both sides. So pumps well. It is the major systemic one. What about the right ventricle? So right ventricle, we know the shape is not cylindrical. It is kind of a very different, multiple planes are there. It is trabeculated. There is a heavy trabeculation there. You may see a moderator band at the lower end in the right ventricle. Now, if you look at the valves to decide whether the right side and left side, can you see that the tricuspid valve is slightly below or closer to the apex of the heart if compared to the mitral valve? So that is a very important sign that is called natural, or it's called a normal offsetting of the tricuspid valve. So the tricuspid valve is the, you can see that there is a one leaflet that is attached to the septum. You can see that it is attached to the septum. It is a 3-valve leaf, there are 3 valves, 3 leaflets, and one of them is attached to the septum. It is slightly more apical compared to the mitral valve. So if you see that this is there, you can conclude it's a right-sided ventricle. And if you see the normal offsetting, you can rule out AVSDs, you know, the the canal defects, basically. Now, what do you look at? So you can assess the function. So whenever you are looking at a heart, you can look at what is called eyeballing. So eyeballing is basically looking at how the ventricles are contracting. It's a reasonably good kind of, if you have done many normal echoes, it's a very reasonably, it's a reasonable thing to understand the function of the heart. So what happens? The heart contracts. You can see that all the ventricles are contracting well, and you can see that the mitral and tricuspid valves are opening completely and closing like this. So if the ventricle is not contracting, there is a regional wall motion abnormality. You can see that the valves may not be opening, and just looking at them, you will know which ventricles or how they are contracting. This is called eyeballing, very important in function. This is one of the first steps there. The other thing is, what you can do is start doing Doppler. So you look at it systematically, the mitral valve. So you look at the mitral valve. You can do a Doppler of the mitral valve. So we'll show you when we do a color Doppler. So you see a uniform orange jet because it is going down towards the probe. So what do you look at when you do a Doppler in the mitral valve? Is it there in the next one? Yes. So this is the mitral valve Doppler. So what do you see? When you do a mitral valve Doppler, you see 2 waves there. These are called the E and the A waves. The E wave is the early diastolic filling. So when the mitral valve opens, there is a lot of blood that comes from the pulmonary veins, and there is a filling of the ventricle, the left ventricle. So that is the early diastolic phase. And then there is a A wave that comes, that is the atrial contraction phase. So typically you should know that in term babies, once they are fully term, even when they are term, you should know that the heart is not as contractile as a child or an adult. So it has more, the compliance of the heart is less. So what typically happens is the E and A are almost the same in a term baby. But what happens in a preterm baby? In a preterm baby, what happens? The heart, the compliance is very less. So the passive filling, that is the early filling, will be lesser, and there will be more filling when the atrium contracts. So that is called the A wave. So what typically happens is the E by A ratio will be less than 1. Mostly in preterm, and as they get term also, it may be up to 1. What happens in a PDA? What happens in patent ductus artery? Yes, next. So you can see that this is how the arteries are sitting. So they are crossing. You can see that the LVOT was like this. Okay, the LVOT was like this, and this is the RVOT, and the pulmonary artery, it is like this. So they are crossing each other like this. So this crossing is normal. So if there is no crossing, like a transposition of great arteries, when there is a parallel, both of these are sitting parallel, in this view you will see it. You can see the right ventricle, there is the RVOT, that's the main pulmonary artery. You can see the branching of the pulmonary arteries in this view. So basically you are sweeping from here posterior to anterior, you will get these views in the subcostal view. And then there is the bicaval view. So basically it's again a little slanted here, we'll show you. So here you can see the superior vena cava and the inferior vena cava entering the right atrium. So you should always ensure that you see the vessels entering into the chamber. So like I told you earlier, in this you can see the right atrium connected to the IVC. Here you can see the right atrium connected to both SVC and IVC. Here you can even do like a measurement. See, some people talk about the SVC flow. It is good whenever there is a PDA to assess the systemic flow. So this is one place you can measure. You can see there the SVC. This is the superior vena cava. This is the jet. You can do a VTI of the superior vena cava. Although the SVC flow, we typically don't do. There are many issues. You have to take many measurements. Sometimes it's not very reliable. But this is one of the places where you can have a look at the SVC. So you get a lot of information from all these views. That's all. I think in the interest of time, I'll stop.
So apologies for that. Actually, I am Dr. Venkat. So Dr. Nilesh, we both actually had been interacting with you. Dr. Ankur, the first talk we gave us to us. So 3 of us are here. Dr. Kamal actually is here, and Dr. Shekhar actually is here, who actually is the main person in the event. You know, jinki bina wo ho nahi sakta tha. Great. So we are trying to actually do the virtual thing again. Somebody is trying. So few words I want to actually add to the talk what has been told till now. What do you think is the most important actually attribute or to quality to actually understand, do an echo? We have been hearing since morning 2 talks, various views, physics of ultrasound, all these things. What is the most important thing? जो मुझे लगता था ये सबसे important है. So I tried, I practice. Visually, mentally, sleeping actually, then I could reach some extent. What is the quality? It's a common quality, not a medical term. It's a normal term. It's an English word. We say, like in adult medicine during MBBS, we go and check for higher mental functions. We ask them for time, place, person. What do you put that word called? Orientation. The most important thing you require is orientation. And orientation cannot be taught. You have to orient yourself. And orientation has to be 3D. 2D orientation doesn't help in heart. Because heart is not a flat structure. Even though it looks like a flat, there are 4 chambers and arteries are coming out and going in. It's not like that. We all know that very well. So each and every structure actually has got a different relation to each other. For example, aorta and superior vena cava. So how do you think aorta and SVC, what is the relation between these 2 structures? When aorta is going out of the left ventricle, like this is LV, aorta is going out like this. SVC is coming actually from the top inside to the right atrium. What is the relation between aorta and superior vena cava? How they are placed to each other? Can somebody describe? Can you tell, ma'am? What is the relation? Right, left, anterior, posterior, superior, inferior. Use all these 3 different actually ways of describing. What do you think actually? What are the all possible ways of relation between these 2 structures? They're very important actually. Because unless you know that how they are really placed to each other, identifying a particular structure in an echo as SVC and aorta is very difficult. Because unless you know that what is a normal pattern, identifying something abnormal would be actually virtually impossible. Whatever we talked till now, so unless you orient yourself, because aorta is to the left of the body, superior vena cava is to the right of the body, it means that more lateral, aorta is more medial, SVC is more lateral. That's fine. So right to left relationship. What about AP relationship? Which one is more anterior, which is more posterior? Aorta is more in the front and superior vena cava is more in the back, more posteriorly placed. So it's not only right left, lateromedial relationship. One is in the front and one is behind also. So one example I gave. So virtually everything, because Dr. Nilesh said a very nice point. In TR jet, when you look at actually the RV jetting into right atrium, which is not normal, it's abnormal. So in a TR jet, you may not really get a jet many times, but there will be a jet you may miss it. Why it is so? Because RA and RV, they don't have only a superior inferior relationship. They also have a different relationship. Which one is more behind? In RA and RV, RA is here, RV is here. So RA is above, superior, RV is below, inferior. Is that all or something else is there between them? So RA is more posterior and RV is the anterior most chamber. So when the blood flows from RA to RV, the blood flows from back to front, normal. It means that abnormal flow from RV to RA, the blood flows from front to back. So it's not only actually below upwards, it's from front to back also. So sometimes if you don't align the probe appropriately, you may actually miss the front to back relationship. You may think actually there is a lesser flow or there is no flow, and you say there's no TRZ, no pulmonary hypertension. It may happen so. It's very important. One point I want to actually send you. Second important thing is we failed to tell in the last two lectures. I thought it's very important to tell actually is that when you talk about a probe and probe manipulation is very important. Probe manipulation. It means that you manipulate the probe to get what you want to see in the heart. And how do you manipulate? Manipulation has three common ways of manipulating. One is called rotation movement. Second is called angulation movement. It's very important. Pay attention. One is called rotation movement. Second is angulation movement. And third is called swiping, sweeping, tilting. All are same movement. From the echo point of view, angulation is the least important. We will not do much angulation in this. I'll show you what exactly it means. That rotation is important, but the most important is sweeping or a tilting motion. Now, how do you understand that? I'll tell you actually with this small example. I just put the probe down. This one is the probe.
In the same picture, we will get to see a few colors. Now, traditionally, anything which is flowing towards the cursor. So here is the cursor, echocardiographic probe. So towards the probe, any flow towards the probe will be marked as red. Any flow away from the probe is marked as blue. So here you can see that the left pulmonary veins are draining into the LA. The LA blood is going to the left ventricle. So they all are marked as red, and then it is flowing towards the aorta, which is marked as blue. The color is less as compared to the blood. If the blood flows directly towards the the probe, then it will be like a bright red. Now it is appearing a little dull red because of the Doppler shift and the angle cos theta which is there. So basically, beam is coming like this and blood flow is like this or like this. So that's why we are not seeing very bright colors. But this is how it is. So blood going in this direction and then in this direction. So what are the uses of the parasternal long axis tube? We can take some measurements. We can do, so this is the same view. This is LA, this is aorta, and this is the aortic valve. You can see the aortic valve leaflets. So one leaflet and another leaflet. So at the base of these leaflets, where the hinge is there, we place our cursor and we get to know the diameter of aorta, and which is 6.3 millimeter in this particular picture. We can also do the measurements of left ventricle. So for this, this is the same view, the right ventricle, left ventricle, and this is the mitral valve, and this is the aortic valve. So we have to this is M mode line. So we have to put this M mode line in the left ventricle such that this line just cuts the tips of the mitral valve. So here is the mitral valve. So it touches the tips of mitral valve. When you place it appropriately, you will see this is the cross-sectional, this is the M mode tracing. We will see that this correspond, the top one correspond to the right ventricle. The middle one, this is the interventricular septum, and this is the interventricular septum. And below it, the farthermost, this is the bright structure is the pericardium, and this is the pericardium. This is the posterior wall, which is also depicted here, correspondingly posterior wall. And below interventricular septum and posterior wall, you can see two lines. One is this line. This is one mitral leaflet, and this one is the other line, this is the other mitral. So you can see the two mitral leaflet. Now we have to define the diastole and systole. So basically the mitral leaflet will come together during the systole, and they will open up during the diastole. So when they are coming together, like in this phase, this is the systolic phase. So this is end systole, and then they will open up. This is the diastole, and once they close, that is again the end diastole. So you will see that the end diastole will correspond to the maximum diameter, and end systole will correspond to the minimum diameter. Correspondingly, this is end diastolic diameter and end systolic diameter. So these are the diameters which you get. The best way, these are the two ways to get it. The best way is correspondingly, if you have an ECG tracing also available, which comes at the bottom of the slide. So if ECG tracing you have, then the R wave corresponds with end diastole, and T wave, end of T wave corresponds with end systole. So there, then you can take this measurements based on any of these three or a combination of these three pointers. So in this picture, we have taken an end systolic dimension of left ventricle. Now we can also take the end diastolic dimension, and we can use this dimension. We can also take the posterior wall thickness, interventricular thickness, and we can use these measurements to find whether our dimensions are increased, whether my left ventricle is enlarged or small, my interventricular septum is thick or thin, my posterior wall is thin or thick, and so on. So there are certain nomograms which are available. You can take help of these nomograms to find the morphometry of the left ventricle. The next comes, you can use these two values, that is end diastolic diameter and end systolic diameter, to find two of the very important indices which are used in day-to-day clinical setting, that is flexion shortening and ejection fraction. Now, again, the beamline is aligned such that it cuts the tips of mitral valves. Now, once you do this, again the same tracing will happen. We will take end systolic and end diastolic diameter, and then we feed it into the computer, and computer will calculate fraction shortening by applying formula end diastolic diameter minus end systolic diameter divided by end diastolic diameter into 100, and it will give you certain value. Now, if this value is between 25 and 40, it means that our systolic functions are okay. If this value is less than 25, it means that there is systolic dysfunction. The ventricles are contracting poorly. The left ventricle is contracting poorly. Similarly, you can have ejection fraction. If the ejection fraction, it is simply it cubes these two measurements and give us ejection fraction, and it will, any value less than 55 will be considered as a low ejection fraction. So these are the two values which are derived from the 2D in the parasternal long axis conventional view. The ejection fraction can also be calculated by the empirical view using Simpson method, but this is the classical method which is used. Okay, so we can also, the next application is calculating the LAAO ratio, in which we place our cursor, M mode line in cutting through the tips of the aortic valve and the it's not tip, basically it is the ampulla where we place, and the diameter of the LA. So LA dimensions are taken and the aortic dimensions are taken. So once we place our cursor appropriately, we'll see that the aortic valve, this is the aorta. So this is right ventricle. This is aortic valve. This is the wall of the aorta, the two walls of the aorta correspondingly, and this is the left atrium. So this is the left atrium. So during the systole, the aortic valve will open, and during the diastole, this valve will close. So you can see these two valves, which are aortic valves, which are open, which are parallel to each other during the systole, when the blood is flowing out of aorta, and during the diastole, they will form a single line, and you can see that this valve is closed. This is the kind of image which we will try to acquire. And once we have these images, then we do measurements. So we take the LA measurements in end systole. When the LA is maximally having the maximum diameter. So this is the LA dimension, which is depicted at 1.43 centimeter here, and we take the aortic dimension and aortic diameter, and then we will get the LAO ratio. So any value of more than 1.4 is considered that the LA is dilated, be it because of, most likely because of presence of increased fluid. Maybe in cases of PDA, maybe in other cases of volume overload. Okay, so we can also use these views to form the, views to yeah. So we can also use these views to judge what is the eyeballing. This is eyeballing to find whether my pulmonary pressures are elevated. So this is normal view. First concentrate on this view. So this is the normal contractility of the ventricle. So where the interventricular septum is more or less straight. If you compare the in the interventricular septum is bulging inside the left ventricle. So this is a right ventricle. This is left ventricle. Now this is kind of showing a concavity inside the left ventricle. So once this happens, it means that your right-sided pressures are little elevated, such that your the interventricular septum is bulging inside the left ventricle, and you will see that the dimensions of the cavity dimensions are less as compared to the normal contractility or normal left ventricular function. We can also place the color Doppler, and this color Doppler shows that there is a red color jet which is originating somewhere in the left ventricle and going towards the right ventricle, and this is the flow across the muscular VSC. So if you get that, then you can diagnose that there is a muscular VSC, and you can get the dimensions if by placing the you can measure the dimension of VSC. So this now we have finished the uses of the classical parasternal long axis view and its various uses. Now we'll see two variations of parasternal long axis. In the classical view, the parasternal long axis, the ultrasound beam was cutting the heart exactly in the midway, such that we were getting the left atrium and right ventricle. Now, if we have to, we need to know that. You remember that during the classical view, our left ventricular inflow as well as the outflow were available in a single section. Okay, the left ventricular outflow is anterior and inflow is posterior. But the right ventricular inflow and outflow, they are not in a single plane. They make a right angle. And how they make? So this is right atrium. Now from right atrium, the blood flow goes to the right ventricle. Now this is right ventricle. Posterior to the right ventricle is left ventricle. So this is part of left ventricle. Majority of the structure which we are able to see on the front is right ventricle. So from blood will flow from the right atrium to right ventricle in this direction. And this is pulmonary artery. It is originating here and it is going like this and posteriorly, and it is dividing as left pulmonary artery and right pulmonary artery. So it is flowing from the right ventricle, blood is flowing from the right ventricle in the right ventricular outflow tract in this direction. So blood is coming in this direction and flowing in this direction. So if we have to interrogate the right ventricular inflow, we have to sweep our ultrasound beam in this direction, and if we have to study the right ventricular outflow tract, we have to sweep our beam in this direction. How this is done? Let us see. So if we sweep our beam to the right side, the classical one, parasternal long axis, we will cut the right ventricular inflow tract such that this is RA and this is RV and this is the tricuspid valve and this is IVC. So we will see the flow of blood from RA to RV. So how it is looked at. So this is how you need to do. So how do we achieve that? Once we place the cutter, cursor in the classical parasternal long axis, we will tilt this probe slightly towards the left shoulder. So it is tilted towards the left shoulder such that the beam goes in opposite direction. Opposite means in this direction, towards the right. Once beam goes interrogate the heart towards the right side, we will see the right atrium, tricuspid valve, and right ventricle. Now this is what we see once we place the opens up the right ventricular inflow tract. This is the tricuspid valve. If we put the color, then we see the blood, the red colored blood or red colored flow, which suggests that blood is flowing from the atrium to ventricle. Here is the probe. So it is red colored blood is going from atria to ventricle, and the blue colored blood, which is going from the ventricle to atria. So this is a tricuspid regurgitation. This is the jet of tricuspid regurgitation. So if we place our continuous wave Doppler here, this is the same, the TR jet, then you will get this nice tracings of tricuspid regurgitation jet. Now, these tricuspid regurgitation jets are used to calculate the right ventricular systolic pressure, which will be equivalent to pulmonary artery pressure. So, how it is done? So, we place our cursor here at the tip of this envelope, and we will get the velocity. The velocity is 432 centimeter or 4.3 meter per second in this case. It will give us the pressure gradient when we place this value in the modified Bernoulli's theorem. That is 4V square. And once we get the peak gradient, that is approximately 75 millimeter of mercury, then it does mean that the pressure gradient across this valve is 75 millimeter of mercury. If you add right atrial pressure, which is 5 to 10 millimeter of mercury, you will get the right ventricular pressure, which is, if we add 10 to this is 85 millimeter of mercury. So pulmonary artery pressure or right ventricular systolic pressure is 85. If we have systolic pressure by measuring the oscillometry technique or invasive BT technique, suppose it is 60 millimeter of mercury, you know that your pulmonary artery pressure is 85, atrial pressure, aortic pressure is 60, so we are having a pulmonary arterial hypertension. So this is the use of this view. Okay, now we will go in the other direction. The right ventricular outflow tract, we will, for inflow tract, we tilted the probe towards the left shoulder, but for outflow tract, this is on the other direction, we have to tilt in the opposite direction so that beam of the ultrasound that sweeps towards the left shoulder. So let us see again. How it is done. So we have to tilt in this direction. Okay. Now, if we do this, the probe will go the beam axis will cut through the pulmonary artery, and once it cuts through the pulmonary artery, we'll see the right ventricle, we'll see the pulmonary artery, and we'll see the pulmonary valve in this section. In addition, we will see the left ventricle, mitral valve. We might see these structures, but these structures, we intend to see these structures. So let us see. So this is the same view what we see in the right ventricular outflow tract. So this is right ventricle, this is pulmonary artery, and this is the pulmonary valve. This is the left ventricle, and this is the mitral valve, and this is the LA. So basically, these structures, we are interested in this structure. Okay. So once we put color Doppler, we will get the blood which is flowing away from the probe from right ventricle to pulmonary artery, and thus we see the blue colored jet. So this is how we see the flow of blood inside the pulmonary artery. If there is a PDA, you might find the red colored jet which is going from the aorta, this is the descending aorta. So from this to pulmonary artery, you can see a jet of blood going. This is not a classical view to look at PDA, because the classical view is high terrestrial view, which will be dealt in other section. Okay, so what are the uses of right ventricular outflow tract? we measure the pulmonary artery diameter, which is measured by placing the cursor on the hinges of pulmonary diameter, and then we get the diameter. When we get the diameter, so this is 6 millimeter in this case, and we use this diameter to measure the right ventricular output and the aortic diameter for left ventricular output. So these are the uses. Okay, so now we have come to the next section. We have finished now the parasternal long axis. We'll now discuss the parasternal short.
Going into the theory part, we'll go into the practical part more because we have less of time. So next slide. So first, we all know the fetal cardiovascular physiology. The most important the part is we have a just a minute. We have a placenta over here, the liver over here, and the heart over here. Next, so we have three shunts: ductus venosus, foramen ovale, and ductus arteriosus. So what is happening is the oxygenated blood comes from the placenta and goes to the liver through ductus venosus. So liver is bypassed because placenta has done all the work. Then the blood goes to the next. This is the first shunt. Goes to the next shunt from the right atrium, goes to the left atrium to the foramen ovale. So PFO, the patent foramen ovale. Then it goes, the lung is bypassed, so it goes to the left ventricle and then goes to the am I audible? Then comes the third shunt, the ductus arteriosus, and then the flow comes to the descending aorta to the abdominal aorta, and then the arteries, the umbilical artery, which goes again back to the placenta. So that these three shunts are clear. So next slide. Next. Okay. So what changes at birth? Next. First thing, placenta is replaced by the lungs as the organ of respiratory exchange. One important concept. Second, the lungs and the pulmonary vessels expand, thereby significantly lowering the resistance to the blood flow. So the lungs and the pulmonary vessels have to expand, so they need oxygen. Subsequently, the pressure in the pulmonary artery on the right side of the heart is decreased. Next. The pressure on the left of the heart increases. So left side ka pressure increase karna and right has to decrease, and the pulmonary has to work. The lungs have to work as a gas exchange organ rather than the placenta. And all the three shunts closes. So now blood enters the lungs for the respiratory exchange. We all know this concept. Next. I'm seeing. Okay. So now the cord. I'll change it. So now what is happening is the blood is going to the right atrium, right ventricle. Next. From the upper part also, it goes to the right ventricle. From the right ventricle, it goes to the lungs. Lungs, the blood is oxygenated and goes to the back to the heart. So there is no shunt involved in all these three. So ductus venosus is gone, foramen ovale is gone, and the ductus arteriosus is gone. Fine. Next. So this is just a schematic representation. We all know this part. Next. Yeah. So now coming to the important topic, what is atrial shunting? So atrial, we are talking about the patent foramen ovale. Foramen ovale ki baat kar rahe hum. So what we need to see in the atrial shunting is the presence of the shunt. Is the shunt present or not? First. Second, if present, what is the direction of the shunt? And this shunt will happen everywhere. For the PDA also, the things are the same. Is the PDA patent or not? Is the ductus patent or not? And if patent, what is the direction of the shunt? And is there any hemodynamic significance or not? And hemodynamic significance is by the shunt and by the diameter of the shunt. Same will happen for the PDA. Jab next PDA ka lecture hoga, same thing will be explained. Next. So where do we see the foramen ovale? In which view? Anyone? In which view? किस view में हम देखेंगे foramen veil को? Subcostal view. Subcostal view. Dr. Nilesh और Dr. Ankur ने समझाया था. In the subcostal view. Subcostal view is the best view. How do we see is slide it to the baby's right, point towards the left clavicle. This is the pointer. This is the pointer. So I'll keep it here. And I have to point on towards the left clavicle. ऐसे रखना और थोड़ा सा नीचे करना है. This is the pointer. ऐसे रखना है. एक फोन देना. So आपने, you have kept it like this. This is the probe. Point towards the left shoulder. Just angle slightly. Immediately आपको दोनों atrias दिखेंगे. Once you see the atrias, you will see the gap. So this is the foramen veil. This one. So right atrium, जो हमारा probe है, probe, which is the chamber closest to the probe? Always right atrium. Chamber closest to the probe is right atrium. Farthest is left atrium. In between the two has to be a septum. दोनों के बीच में septum होना चाहिए. And if the septum में आपको gap दिख रहा है, then this is foramen veil. Am I clear in this? Because this will be more, we'll do the hands-on. But you have to see subcostal view pointing towards the clavicle, left clavicle. थोड़ा सा down करना है, angle it slightly down inferiorly, and you will see the both the atrias. Remember, the chamber closest to the probe is right atrium always. There is no exception to it. Clear? Next. Now, and foramen veil patency cannot be actually checked with a 2D imaging. You have to put a color Doppler. And color Doppler, it was explained that BART, B-A-R-T, blue away, red towards. आपका probe कहाँ पड़ा है? This place. This is the probe. This is right atrium. This is left atrium. This is red color. So what is happening? Blue away, red towards. So the shunt is left to right. Fine, clear na? Right, again, right atrium, left atrium, red color, towards the probe, left to right. So you have, this shunt is left to right shunt. But if you see a shunt which is totally blue color, which means, so, and the diagnosis is TAPVC, which means the shunt, purely right to left shunt cannot happen at the patent foramen veil. Usually that shunt is bidirectional. 99% you will find that shunt is bidirectional. And maximum part of it will be red color. थोड़ा सा blue color होगा. Because the left atrium pressure has to rise. Clear? If I do a fetal echo, it has to be blue color. Because सारा ही वहीं से आ रहा है. Right to left सीधा shunt जा रहा है. Clear? So again in the PPHN also, PPHN, the same thing will be discussed by sir. If the ductus is patent, what is happening to the ASD, why the color is blue there also. So it will be discussed there. Fine. Clear till now? Next. So is the foramen veil patent? This is still we are continuing with the same part. Drop the maximum velocity over there to optimize the shunt. If too high a velocity, you will miss the low velocity shunts. Because the shunt here is between 0.2 to 0.5 meter per second. If the velocity is too high, 0.8 or 0.9, velocity, they will color Doppler समझाया था ना, उसमें side पे velocity. Next come. Better next. No, go back. Sorry, I missed that pitch. एक पीछे और चलना. Yeah, this one. This one is the velocity range. So this, if you set this as 0.89 or 0.78, ये set होती है cardiacs में, और and -78. So you will not be able to see this shunt because this is usually a low velocity shunt, medium velocity, 0.2 to 0.5 meter per second. Whereas the other shunts, the PDA, you will have a higher velocity shunts. Fine. Next. So if to a high velocity, then you will miss the low velocity shunts. Most atrial shunts are bidirectional. Fine. Next. 3 important points when you go through the atrial septum part. Atrial pressures reflect the diastolic pressures or the ventricular filling conditions. So atrial जो pressure atrium में हम measure करेंगे, that is the diastolic pressure of the ventricle. That's in the diastole. Or the ventricular filling conditions, जब हम EA wave बनाते हैं cardiac cycle में. I'm not confusing that, but just remember that line. Next. Two atrial pressures are not in synchrony. That's why the shunt is bidirectional. They usually are not in synchrony. ऐसा नहीं कि right हमेशा left हमेशा ज़्यादा रहेगा. Sometimes the right will rise and you will have a shunt towards this side. Some degree of bidirectional shunt is normal, finding at the atrial levels. Fine. So 3 points. Atrial pressure reflects the diastolic pressures or the ventricular filling conditions. Second, that the two atrial pressures are not in synchrony with each other. Some degree of bidirectional shunt is normal. अगर आपको पूरा blue दिख रहा है, it's a problem. Red दिख रहा है, that's okay. Red के साथ थोड़ा सा blue दिख रहा है, it is okay. Fine. I'm okay with Hindi na in between. Yeah. Next. Okay. When you image the foramen veil, you can easily see the bidirectional movement of the foramen flap. जब हम करेंगे echo करेंगे, you will see this flap. This is the foramen flap. This will keep on moving like this. I am on this side. ये ऐसे ऐसे move करेगा. Bidirectional movements दिखेंगे आपको. And you will see sometimes an atrial aneurysm inside it. हल्का सा एक tissue flap पतला सा होगा, बिल्कुल ऐसे move कर रहा होगा. So that is also okay. That is atrial aneurysm, but a small amount of that is okay. Next. So now based on the diameter, is it hemodynamically significant or not? You can see the flow through this a red color, chota sa red color, or rest is slightly blue. Here you can see the whole is red. So there is significance of this shunting. There is no significance of this shunting. This is just eyeballing. जो हम eyeballing की बात कर रहे थे कि ये important है कि नहीं है. So if you see a shunt like this holds some significance. The second one, the first one doesn't hold any significance. I'm not putting any Doppler or anything here. I'm just telling you an eyeballing significance. Fine. So there is a degree of, so there is a difference in degree of incompetence. So this is more incompetent as compared to this one. This is eyeballing. Next. Okay. So this is already discussed. The atrial shunts have a velocity in range of 0.2 to 0.5 meter per second. So it is important to reduce the scale to optimize the color. Important. If the scale is set too low, the area will saturate with color. If it is too high, you will find just speckles over there. That is the most important part in the atrial shunting. There is nothing more than this in the atrial shunting part. Next. It happens like this. If too high, then this will be the color gain. आपको बिंदियां 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 ऐसे dots दिखते रहेंगे. That is the problem. अगर बहुत ज़्यादा कर दोगे, it will whole color दिखेगा, आपको समझ नहीं करना क्या है. So whenever you optimize a shunt, for any shunt I'm saying, this is for just the atrial part, atrial PDA, for any shunt, you are seeing a TR, whatever you are seeing, you have to optimize, you should know what velocity shunt it will be. Low velocity, medium velocity, high velocity, उसी according scale आपने set करना है. So जब आप, I think sonosite machines, जब आप sonosite machine देखेंगे, you will have the scales, high, medium, low, अपने set करता है वो उसमें. Clear? Next. So if the gain is too high, this will increase the spill over the edges and make sure the gain is adjusted so there is no speckles appearing on the screen. The same thing. Next. So once you have reached, you have found out the ये gap है इसमें atrial part. This is the gap. You have put a color Doppler. Go frame by frame. Slowly उसको frame by frame करना. Where there is a maximum flow, वहाँ पे हम रुक जाएंगे. Advance slowly frame by frame and measure the diameter of shunt at level of the septum using the clearest view of the left to right shunt. Maximum flow and this is clearest view. You can shift the frame. सबके पास eco machine तो है, frame shift करते हैं थोड़ा one by one. So once you make a video is made of small pictures. Same thing happens here. So a whole video is made up of small frames. We call it frames. Like in Sonosite we get 289 frames. So you advance one frame and you find that there is a flow at this level where the maximum flow is there and you can see a clear picture. Measure the diameter there. Fine? नहीं समझ आया? आ गया. Is it okay? Next. So if you see a large velocity shunt is probably hemodynamically significant. According to the diameter, if you measure the diameter, the less than 2 millimeter is usually insignificant. Less than 2 millimeter is insignificant. Between 2 to 4, it means the systemic and the pulmonary pressures are almost the same. But if it is more than 4, it means it is associated with high pulmonary blood flow. Blood flow बहुत आ रहा है उस side से. The QPQS is high. And no, I will not use the word this QPQS, but the pulmonary blood flow has increased. That's it. So you measure the diameter, see if there is a gap, put a color Doppler there, see what the shunt is there, measure the diameter. If more than 4, more than 2, it is significant. More than 4 is definitely significant. Clear? Next. So I told my fellows to send me a video yesterday night, and let's see what video they have sent. So they made this video first. ये open हो जाएगा ना? So we have to go frame by frame here. So, okay, you can see the flow is there. Atrial shunting was there, and it is red in color. So let's go slightly further. I'm not able to stop it. You can see now it's a slightly blue color is there. So there is a degree of bidirection shunt. I'm not able to do it frame by frame, but at least I can make that. You can see this video. Sorry? Repeat it. Okay. Oh, it's actually it is fast, so I thought. You can see there is some degree of blue, but maximum it is red. And I will measure the diameter over here. Fine. Okay. So this is one video they have sent. Second is you can see this. So you can see the probe is up, the right atrium, left atrium, and this is the foramen ovale, patency of the foramen ovale. You can see that it is patent. Just okay. So I told them to put a color over here. You can see the mixing over here. So, and you measure the diameter. That's it. Thank you. Any questions on this? I try to make it crisp so that we remember only the important points. This is a basic. We need not to go into details.
Why, from a bedside pediatrician point of view, why it is important to know the atrial shunt? Whether we talk about ventricular shunt, talk about patent ductus arteriosus, what is the importance in a bedside to identify atrial shunt, directionality? How does it help in a real life practice? How does it help to pick up some diagnosis, some management? That is important.
So you are asking me a question. आप बताना चाहते questions are allowed only by.
So why do you think this is important for atrial shunt? How does it help? Well, you pick up an atrial shunt is there. So how does it help? Can that be normally present also, or is it abnormal all the time? Should look something more than that in atrial shunt. He's saying he should ask you. You should answer. Because see, there are two things. No, one is the patent foramen ovale. You have a shunt across the septum between both the atria. The shunt can be a PFO, can be patent foramen ovale, or can be actually a structural shunt, which would require closure eventually. So you should actually clearly see on with practice, you can identify the SV jet coming in separately and the PFO jet separately. That is very important. Otherwise, you end up saying many newborns are PFO, left to right shunt, but the shunt is actually a SVC flow and not a PFO shunt. Another important precaution you should remember. Both are very close to each other in that location. We'll show that in the demonstration. If you have an adequate time and appropriate subject is there, we'll show that to you. How to differentiate? See, PFO actually would normally have a flap-like structure because PFO is more like a patent foramen ovale. You need to have a foramen ovale would be there and a flap-like thing covering there prior to closure. So whereas ASD is structural defect, you do not have some flap-like closure would not be there. That's one structural way to identify that. And if it is secondum ASD, secondum would be quite higher in location compared to PFO. PFO would be quite lower in location, similar to primum ASD. So, but the simple way is to look at the closing flap would be there in a PFO, it will be absent in a ASD. That's one way to understand that. Any questions till now? So the sequence actually is able to follow through, no? All the views out to see from the physics, then we move to the different views, subcostal, then apical, then suprasternal, parasternal, then suprasternal. You know, that's a way we progressed. Then we had atrial shunting discussion. So now we'll be having the next talk by Dr. Shekhar. I can do mine. Okay. Okay, meconium aspiration, perinatal asphyxia, you know, a newborn who is asphyxiated, who has passed, you know, born through MSL and has meconium aspiration syndrome, term under post-term newborn, no, more mature newborn, or higher the maturity, more maturity, you know, higher chance of perinatal asphyxia, passing meconium, then meconium getting aspirated. That's one set of scenario. Okay, any other set? IUGR, you know, chronically hypoxemic, chronic hypoxia in utero, and if there is some acute on chronic hypoxia, acute insult happening perinatal, so it becomes acute on chronic hypoxia, there could be another scenario. IUGR infant can be there. So should I, you want to? I'll do mine because I started already. So a newborn with some other problem, some primary problem, which could be RDS, which could be pneumonia, which could be like say some aspiration pneumonitis, milk aspiration, blood aspiration pneumonitis, but then has secondary pulmonary artery hypertension. Because there are two groups, no? One is a primary pulmonary artery hypertension, or we call as PPHN, or a persisting fetal circulation, where the higher pressure in utero could not normalize postnatally. That is one scenario. Second is baby has a normal pressure, so normal reduction, then has some other morbidity, and then secondary there is a higher pulmonary artery pressures. Second group could be there. But in the echo point of view, you don't differentiate really it's primary or secondary. So I'm going to look at the heart, look at the pressures, measure pressure, and why it happened, I should look at all the clinical scenario and try to come to a conclusion. It means that echo alone cannot help me to manage pulmonary artery hypertension. Very important point. You should not put a probe, look at TRZ, look at some marker, and I'm going to start sildenafil or nitric oxide, vasopressin. That's not the answer. You should look at why it has happened. Is it primary or secondary? Secondary means what? Treatable. Treat the condition, not the pulmonary artery hypertension. And sometimes additionally, treating condition doesn't help. You want actually an additional support, then you can come to the pharmacological therapy for pulmonary hypertension. That's very important. Okay. Point. We are an echo workshop now. Okay. From the echo point of view, what are the indicators of pulmonary artery hypertension? What do you think? There is a higher pressure in the pulmonary artery, right? Let's go by physiology. So what will happen with the higher pressure in the pulmonary artery? Which chamber is suffering? Right, when it's emptying into the pulmonary artery. Higher pressure in pulmonary artery, so RV has difficulty in emptying into pulmonary artery, right? Clear or not? So what will happen to the RV? What will happen to the RV? RV is under higher pressure. RV is under higher pressure. What will happen to the RV? RV will dilate. You know, it will dilate. So it will dilate. I'll come to that later. So if it dilates, so what will happen to the RV end diastole pressure? It will increase. So RV dilates at a higher pressure. So automatically the RV is going to actually exert the pressure through some other opening. And that opening is a tricuspid valve. So it will regurgitate. Normally you should not have a blood flowing from RV to RA. That is abnormal. So the valve, which is an open structure, actually will give way because of high RV pressure. RV enlarges. So RV annulus, where the valve is inserting, they'll go apart because of RV enlargement. As they go apart, blood starts regurgitating actually into the RA. But when does it happen? During which part of the cardiac cycle? During the systole. During RV systole. When the RV is contracting, strongly during RV systole. So the blood has difficulty to get into the pulmonary artery because higher pressure in the pulmonary artery. It wants to get an easy way to go out. So easier way is the tricuspid valve. It will get into the right atrium. That's the easier way. So that leads to the TR jet, tricuspid regurgitation jet. Clear? That part is clear. What will happen to the RA now? RA is under higher pressure. RA is getting under higher pressure and higher blood also. Because RA is getting blood now from the superior vena cava, inferior vena cava, and from the RV also. So RA is getting higher blood, and RA is actually operating under higher pressure also. The RA will enlarge. So eventually RA will find some mechanism to download the blood somewhere into the left atrium. If there is a patent foramen ovale, so the blood will move from RA to LA through the patent foramen ovale, which will cause a right to left shunt or a bidirectional shunt with a R to L component higher than the left to right component. You can have bidirectional shunt actually, but the shunt, if you look at the proportion, it will be shunting more from RA to LA than from LA to RA. Clear? So now what is happening? RV is enlarged, valve has gone apart, regurgitation, RA is enlarged, pressure is higher in the RA. Now RA is going to push blood into the left atrium. So you can find actually a TR jet and a right to left shunt across the patent foramen ovale if it is there. If it is not there, you will not find anything. You will find only RA is enlarged. Now what will happen to the SVC flow? RA is enlarged. So when the RA is enlarged, RA cannot actually receive blood appropriately because RA actually is under higher pressure now. So what will happen to the SVC flow that is coming inside blood? It will decrease because superior vena cava cannot actually pour blood into the RA comfortably because RA is already enlarged and higher pressure. So the SVC flow velocity will decrease. By some mechanism, if I can look at SVC flow velocity, it will go down. So there are some normal numbers are there. If you look at the numbers will be lesser than what normally it should be. So the whole chain of events, RA from RV, then RA shunt happening here, then less blood coming from the superior vena cava, right? Now what will happen to septum? One is shunting. When the RV is under higher pressure, what will happen to septum? Interventricular septum is a wall sitting behind, no? Between the RV and the LV. So it is going to push the septum into the LV. Normally, like normal individual like you and me, which is stronger ventricle? LV stronger ventricle. But in a newborn, perinatal asphyxia newborn, only 12-24 hours old. Which one is stronger? RV is stronger, LV is stronger. RV is stronger because RV has supported the whole circulation throughout the 9 months. So RV is stronger. So despite RV is stronger, after birth, which one is stronger now? Which one is doing a bigger job? LV or RV? LV is doing a bigger job. No, RV is stronger. RV is more muscular. RV looks more trabeculated because RV is bearing the whole brunt intrauterine. But postnatally, when circulation, the whole thing reverses, so LV is doing actually a bigger job by supporting systemic circulation, high pressure circulation, right? So now what will happen? Normally, LV would not allow the RV to push the septum towards LV. LV would retaliate, will stop it. Even though RV is stronger, but LV actually would not allow the septum to come towards it because LV is operating under higher pressure. LV has doing actually bigger job than RV. So, but the earliest sign when there is higher pressure in the RV, during the end systole, the RV will overpower LV. If there is a high pressure in the right side because of high pulmonary artery pressure, the first sign is septal shunting, a septal movement, as you said rightly. But the movement happens, the first time happens only in end systole. When you look at actually the septal movement, always look for the movement at the end of the RV systole. Correct? Because early portion, LV is still stronger. But the later portion, RV under higher pressure, now it is more strong. It will push septum towards LV. As the time progresses, as RV becomes stronger and stronger and more muscular because of higher pressure, it will happen through the whole cycle. But the earliest sign actually is, at the end systole, the RV is going to push the septum towards LV. What will happen to the atrial septum? RA is stronger. Under higher pressure, septum would move towards the left atrium, right? So we saw the shunt, chamber enlargement, jets, shunt, septal movements. These all are echo signs of high pulmonary artery pressure. It's very important. I'm going sequentially so you all understand that. Now, what will happen to circulation later? There is some more communication happening there. Where and all you can see actually the effect of high pulmonary artery pressure apart from this? Which other blood vessel you can actually use to measure the pulmonary artery pressure? I can look at the RV size. I can look at the TR jet. I can look at the RA size. I can look at the SVC flow velocity. I can look at the RA to LA shunting. I can look at the septal movement. After that, where else I can see? Okay. So, where is the problem now? In pulmonary artery hypertension, where is the problem? In pulmonary arteries. Pressure is high where? In pulmonary artery. So can't I see pulmonary artery directly? I can look at pulmonary arteries, no? I can look at the right ventricle and outflow tract right ventricle, main pulmonary artery. In the short axis view, and it was shown very nicely, right ventricle is the topmost thing, anterior most thing. And the right ventricle opens into the outflow tract. From there is the main pulmonary artery, then branch pulmonary arteries, both are right and left pulmonary arteries. I can put my probe, whatever PW, CW I can put there in the main pulmonary artery, and I can get some Doppler image. I can do some measurements, and I can understand something as the pressure is higher in the pulmonary artery. That is one way where I can look into. There is one more vessel which I can use. What is it? If it is open. Is it working? Is it working? Huh? There is one more vessel, PDA. So PDA, if it is open, is another vessel which is communicating between the systemic and pulmonary circulation. When the pressure is higher on the pulmonary side, automatically there is going to be a shunt reversal across PDA. If there is a larger PDA, no pulmonary artery hypertension, the shunt will be left to right, from the aorta to the pulmonary artery. But with higher pressure in the right side, it will become bidirectional. Is still higher, it will become right to left shunt. It can become complete also. So you can actually look at the proportion of the shunt across the PDA, and if it is beyond certain number, you can say, okay, the pressure in the right side is higher, causing the proportion shunt actually to be more than certain percentage. That's another way. So these all are the common ways to look at the pulmonary artery hypertension. Some are called actually direct measures, some are called indirect measures or semi-quantitative measures, and some are qualitative measures. So which are actually quantitative in this? Direct measures, which can give you the actual pressure. Out of all I told you, which one can give you the direct pressure? This one is TR jet. Because TR jet, by some mechanism formula, I can know the velocity. The velocity I can convert into pressure, and that pressure would be the RV pressure. And if the RV is normally functioning, very important word, underline this, if the RV is normally functioning, it is only reflecting the pulmonary pressure to us, otherwise RV is fit and fine, then the TR jet velocity you convert into pressure, whatever I get I can call pulmonary artery pressure. But RV should be normally functioning. If RV is dysfunctional, because of whatever reason, because of perinatal asphyxia, long-standing pulmonary artery pressure, RV actually become ischemic, tired, not normally functioning, then your recording would not be appropriate. Because RV is not transferring the pressure from the pulmonary directly. RV actually is tired now, not reflecting whatever is going on. Become less compliant or more compliant, not normally compliant. Fine. Another way, direct pressure is only one way is there for TR jet. Any other way? Any other method to measure pulmonary artery directly apart from this? PDA? See, there is a phenomenon called Bernoulli's phenomenon, which will tell what exactly it means. The same phenomenon can be used for across PDA also, and you can get the pressure in millimeters of mercury. Only two measures, TR jet and across PDA, you can understand the pressure in the pulmonary artery. So these two are direct measures. So what are the semi-quantitative measures? Which will give some idea, give some numbers, but not the actual number. So like RV size enlargement, RA enlargement, pushing septum, they all are qualitative. You can visualize them, but it will not give some numbers to you. Why numbers are important? Numbers are important to manage. Numbers are important to look at actually that, okay, it is X number at this point. I had made some modification, like say I put them on nitric oxide, sildenafil, and the number has changed now to Y number. And Y is better than X. So my therapy is working. So numbers help to understand how things are changing. That's the only advantage. Numbers, scores, all are there actually to monitor, look at the change. It means that sequential monitoring, serial monitoring, numbers give an idea. So semi-quantitative actually would not give much of idea. One example is main pulmonary artery measurements. Look at the main pulmonary artery, put the probe there, you get something called time to peak velocity. You don't get the actual pressure, you get time to peak velocity. Otherwise called PAAT, pulmonary artery acceleration time. So how much time it takes for the blood that gets inside from the RV during RV systole. So how much time it takes to reach the peak, time to peak velocity. What will happen if the higher pressure is there? When there is higher pressure in the pulmonary artery, so RV actually would end up reaching peak earlier or later. What will happen? Earlier. And what will happen to the peak? One is time, but what will happen to the peak? Will be shorter peak or deeper peak, longer peak? It will be shorter peak, because RV can empty less blood into the pulmonary artery because of higher pressure pulmonary artery. Because of higher pressure, RV empties less blood inside. That will be shorter peak and an earlier peak. So RV systole becomes shorter and ends earlier, and then becomes normal. So a shorter peak and an earlier peak is a characteristic pattern of pulmonary artery pressure, higher pulmonary artery pressure. And sometimes you can get actually a notch also, because higher pressure you can find actually an W-shaped or a reverse M-shaped notch also can be seen in the pulmonary artery Doppler recordings. But it still gives some number to you. You can have a time to peak velocity, you can have a ratio also, but these numbers are not directly measuring pulmonary artery pressure, but it will help you to understand the management to some extent. So those are called actually semi-quantitative, not actually fully quantitative. Rest all are qualitative. Rest all are qualitative. You can use something called TAPSE as a part of tissue Doppler and all. That tells about RV dysfunction. It doesn't tell about pressure actually. Because of higher pulmonary artery pressure, when the RV becomes dysfunctional, then the TAPSE gets changed. So measuring pressure, TR jet across PDA, direct measurements, semi-quantitative, time to peak velocity in the main pulmonary artery, rest all are qualitative. You can visualize it, but it doesn't help you to manage. Okay, I'll rush through presentation very fast. Can I sit here? And the tube in between actually could be a PDA or could be a TR jet also. 4V square formula, that's an example. So I hope the video works. कहाँ से आता video? Okay, it's not working. Fine. So this one is a typical actually 4-chamber view where you should look at the TR jet. So this is a 4-chamber view. What are those on the right side? Structures on the right side. You have a laser pointer? No. No pointer. Okay. What is this one? Be loud. Right atrium. What is this one? Left. Be loud. Make mistakes. What is it? Left atrium. Okay. And what is this? Right ventricle. And this one is left ventricle. How do you know? Well, how do you know How do you know that means right atrium, left atrium? How do you know? Because I told the right side, so I said all right side or RA and RV. But I couldn't see trabeculation in this. It's a still image, no? Okay. So it's again a separate topic to identify chambers, but briefly, sir, you told actually you should look at the valve position. So this one actually is the starting of the septum, ventricle septum. This point, this one leaflet of tricuspid valve. This is a mitral valve leaflet. Normally, the mitral leaflet will be higher in position compared to tricuspid valve. So this side actually is the tricuspid valve, and this would be the RV, right ventricle. You should look at something called as a moderator band. You know, you can find actually an echogenic structure in the right ventricle. It's called moderator band. In a still image, we're not able to see it, but you can see in a video. We'll show in the demonstration time. So this one is right atrium. You should look actually here. This is the point where the RV to RA jet happens here. So you should put the cursor between the valve leaflet tips at this location, between the annulus. Put your cursor, and it looks like this. It's a TR jet. You put your cursor somewhere here, this location, here. Not here into the RV, not here into the RA. At the level of the annulus, where the valve is inserting. That's the location you should put actually the cursor here in this location. And you get a jet like this. This one actually again illustration. So you should actually measure from the baseline to the peak. That's a peak velocity. From here to here, peak velocity. Square the velocity. And then you multiply with 4 and you get 4v square. So that's the way you should measure it. This is an example again. It actually has a video, but it's not running because of... Yeah, it's not running actually. It's a long video. Right. So across ductus you can do same thing. This one is a patent ductus. So you put across the pulmonary end. This is a ductus, pulmonary end. This is aortic end. You put the cursor in the pulmonary end and apply the same principle. So there will be actually a right to left shunt from here to here direction. Put here, there's a blue jet, would normally look like this, and get the velocity, square the velocity, and multiply with 4, get the 4v square and pressure. Across ductus is less reliable than TR jet because ductus is not a uniform structure throughout. It's tubular. At some points wide and some points narrow. So you not get the real reflection. But TR jet for some reason not able to measure, then you can use ductus to measure it. That's alternative. So this one is a ductal flow pattern. I said no, you can have a shunt bidirectional also. So you should look at the ductal shunting direction, which we'll talk more in the next talk with Dr. Shekhar. So briefly, this one is a Doppler actual picture. How does it look like? Called a spectral Doppler. So any flow towards the probe would be seen above the Doppler, and any flow away would be seen below the Doppler. So in a ductus, if there is a high pressure on the pulmonary side, it will look as blue, and those all will be seen actually below the Doppler line, below this line. So this one is right to left shunt flow and left to right shunt flow. So you measure from this point to this point, total time taken from this point of the whole cardiac cycle, whole flow, the flow duration, and you take off only this portion. If this portion is more than 30% of the whole flow, then you say that the shunt is significant, the pressure is significant in the right side. That's a rough ballpark figure you should remember. 30%. More than 30% means significant shunt is there. These are various patterns, how it changes. I will not get into all those things. This one is same again. Look at the total flow time across the ductus, and then you get the total across ductus, and only this portion, if it is more than 0.3 or more than 30%, then indicates a higher pulmonary artery pressure is there in the pulmonary arteries, indicating by the ductal shunt. And if it is complete, it looks like this. Complete blue jet, nothing is there above the line, all are below the line. These all are various patterns, you know. So complete shunt looks like this. Bidirection looks like this. The same has been drawn here for you. A complete has been drawn here for you. A bidirection has been drawn here for you. Rest all left to right shunts, which we'll talk in the next talk. So that's a mechanism. In pulmonary artery pressure using ductus, you do a little different actually one. How do you get the actual pressure? How do you decide the management? I apply the formula 4V square in TR jet. I got some 60 millimeters of mercury. How does it help me? With what do I compare that? How do you know it's normal or not normal? In adult population, you have certain numbers, no? More than 20 you call mild, more than 40 you call moderate, more than 60 you call severe or critical. Then you end up managing. But in newborns, there is nothing like, you have more than 20, 40, no numbers are there. How do you manage then? How does it help for management? Like say I apply 4V square formula, get some number 60. कैसे मुझे help करेगा? So what we should remember always is that number suprasystemic or not? Always compare systemic pressure. If it is suprasystemic, you should manage. If it is not suprasystemic, wait and watch. And suprasystemic, which component? I have a systemic blood pressure, systolic, diastolic and mean. So which one I should take? Diastolic, mean. Any other answer? Diastolic, mean. Should be mean? Okay, it should be systolic. So what you get actually here is systolic pressure in the pulmonary artery. It should be actually peak pulmonary systolic pressure is what you are measuring by the 4V square. And it should be more than the peak systolic systemic pressure, not diastolic and mean. So always look at that. The RVSP greater than systemic systolic pressure, then you should manage. That's a one rough guide. So don't look at diastolic and mean pressures and all. The same way, if you measure same pressure across the patent ductus arteriosus, you do a little different one. How do you calculate that? So pulmonary artery pressure, how do you get that? See the formula there. They got actually three pressure from 0 to 3. It's a ductus arterial, PDA. PDA, patent, right to left shunt. I took the right to left shunt component and I got 3 millimeters of mercury pressure. So 3 square, you get 9, 4, 9, 36 millimeters mercury. So what I should do? You have to subtract that number actually from what? What is 60? Look at the PowerPoint. 60 is the peak systolic pressure. So you have to subtract the number from the peak systolic pressure 60 minus 36. So actual pressure is 24, not 36. So in a PDA, you have a different formula. We'll talk in the bedside how to apply that. Because we are short of time, we'll move ahead. But TR jet you do differently. Across PDA you do differently. You do same measurement, but the calculation little different actually in there. I'll tell in the bedside in the stations. So this time to peak velocity. So this one is a whole RV ejection time. This is a whole RV ejection time from this point to this point, RV systole. And from this point to this point is the time to peak velocity. In this example, it is 230 milliseconds RV ejection time from this point to this point. From here to here, that is this point, it is 100 milliseconds. So 100 upon 230, how much it is? More than 23%, more than 24% is normal. What will happen if there is a high pulmonary artery pressure? This peak will move actually closer, will become here. And the peak actually becomes shorter also, will be here. So it will be somewhere here, in this location. So how does it look like? It looks like this. The peak becomes shorter. Sometimes you can have W pattern also. There's higher pressure, shorter peak and an earlier peak. That's one way to understand the change. So these are the rough figures. Ratio less than 0.2 is severe pulmonary pressure hypertension. 0.2 to 0.3 moderate. More than 0.3 mild or normal. Rough figures you can consider to manage. Waveform I told you, no, this is a normal RVT. That's a AT or acceleration time, and that's a mid systolic notch. Normal, moderate, and severe. So these are certain patterns you can identify to recognize. You may have sometimes pulmonary regurgitation also. You don't have any numbers for this. If there is a PR, pulmonary valve, because high pressure, so you can have a pulmonary regurgitation jet also in that. But that doesn't have any quantification, is not there for that. That's all. Nobody said for you. Okay. Any questions in this? We can address. Any questions or any queries?
Prepared too much. My background is I'm Dr. Shekhar Subaya. I'm a neonatologist. I'm a founder of Kangaroo Care Group of Hospitals. It's Women and Children's Hospital and Fertility Center. So I started 10 years back in Australia doing the scans, but I'm just sitting at the basic level continuously. I have people like Dr. Venkat, Dr. Venkatesh, Nilesh, everybody has gone up doing more because of my administrative role. So my topic is PDA. PDA is very, very simple and also very essential. How many people are doing PDA? You know, if you do a scan, how many people can pick up a PDA? Just anybody here? Okay, so then I'm saved. Okay, so PDA, finding PDA is very easy. What exactly you do when you find a PDA? Is it patent or constricted? Number one. Number two, is there shunting? Okay, means direction of flow. Number three, other associated flows in pulmonary artery and descending aorta. And fourth is it hemodynamically significant? These four things. We have learned from Royal Prince Alfred Hospital. There's a very good CD. I was just listening to Dr. Venkat. He was mentioning about Canada. In the same way, they started first. We in 2005, 2006, we all follow that CD. It's really good right from anatomy and part 1. Part 2 is a clinical echo. It consists of head and cardiac. And nowadays we are doing abdomen, we are doing hip, we are doing lungs. So it has been upgraded. So if you buy that CD, you don't have to listen to any talks. We always go back and see that CD, make some pictures and come back and talk. I'm telling you, frankly. So there's nothing more, so detailed and so simple. I hope Dr. Nilesh and Dr. Venkat, Dr. Venkatesh must have gone through the CDs, okay? So, yeah, keep going. No problem. So these are our hospitals, these 5 years, just want to be proud of these are doctors driven hospital. So this is not a corporate hospital, so I thought I'll just put Bangalore, Mysore and fertility centers, and we are going on to clinics and keep going. So as I said, again, PDA management, diagnosis, everything is complicated. It is very individualistic and it all depends on how you've been trained and what you think and how is your approach. So, and it has got many interconnected factors, both intrinsic and eccentric factors. And just rush through this theory. So if you see the slides, you can see there are so many antenatal factors, neonatal factors, working on pulmonary overcirculation, systemic hypoperfusion. These are only things PDA will do. Pulmonary overcirculation and systemic hypoperfusion. So when you're looking for duct, you have to look for all these factors. That is pulmonary overcirculation and systemic hypoperfusion. So gold standard is doing an echo. So direct method is looking at the duct size, okay, measuring the duct along with color Dopplers and looking at the shunt, left or right to left. Usually it is left to right and right to left is very rare. And is it constricted? So on. And the indirect methods are looking at the pulmonary overcirculation, that is left pulmonary artery overflow, and again systemic hypoperfusion, looking at the descending aorta steal phenomena, which I'm going to tell you later. Okay? Yeah. So other surrogate markers are LI aortic ratio. I'm not going to touch on this because this is a basic course. And again, you can look at the LV output. We have in that slide LV output and RV output very easily given. We have to measure the diameter of the valves and look at the Doppler flow. The machine will calculate. If you don't know the formula, always set up in the machine. It will calculate for you. You don't have to struggle. Yeah, we'll go. So again, you need color Dopplers to measure the PDA and its effect. So first we need to see in the 2D and then color Dopplers and the flow. In 2D, you can always make out the diameter, and sometimes if it is constricting, it is very difficult because some of the closed PDA and some of the constricted PDAs will mimic similar. Okay, so you need color Dopplers at this time to measure accurately. The only problem with color Dopplers is it should not spill over. Okay, the color should not spill over. Even the Doppler flow also, it should not spill over. We should have a proper scaling of the Dopplers. So as I said, look for anatomy, is PDA present, grading, direction, and hemodynamically significant PDA. Okay. So there are so many studies, and I always follow RPA. And Nick Evans is our teacher, and he always has given a proper meaning to the cardiac echo. He was the first person to start. So this is what we have to look for. 1.5 millimeters is very insignificant. 1.5 to 2. Significant if you have other things like steel phenomena, or if there is a increased flow in the diastolic flow of LPA. Okay, and duct more than 2 millimeters is usually significant. So this is anatomy, I think you know. Okay, how do you image the duct? Many people do it differently. We always think in a, Dr. Nilesh spoke about the views, ductal view. So we always think as ductal view. So just keep the probe here with the marker up, and you can see the descending aorta arch. So just slide it. You can see both the vessels, that is pulmonary artery and the descending aorta. Then you can catch the duct. It's very easy, just here. Okay, like this. If you practice, it will be easy. So views are very important when you are learning. Once you practice, you'll forget the view. Ask me, I forgot the views. We just keep sliding the probes everywhere. I hope other of my colleagues do the same. Just go like this. The best thing is keep the probe here. You can see 5-chamber heart. You can find out many things. Okay, just the practice. Okay, so to learn about the duct, just a view here. See here, ductal view. Two things you can see here. One is, as soon as you slide the probe, you can see the arch of the aorta, and you can see the pulmonary artery, and you can see the duct if it is present. So if you are seeing the arch of the aorta, always you can diagnose one more condition, coarctation. If you do it properly along with Dopplers, that is further. Okay, and sometimes you can look at the ET tube also. If the ET tube is not crossing the arch, means it is in the right position. You don't have to do X-ray also. Okay, there are many things you learn with echoes. Okay, and Dr. Nilesh was showing about the UAC, UVC. It's easy, very easy, subcostal views. Okay, you don't have to do X-ray also, to be frank. Okay, right. So again done. Yeah. So in 2D pictures, we can miss the size of the duct. So use color Dopplers. See again, thumb rule. 2D first and use color Dopplers to measure the ducts properly. Okay, right? So yeah, you can see the, if you see this picture, it is more like how we do the echo. You can see the main pulmonary artery, you can see a small PDA, you can see the left pulmonary artery, and slightly descending aorta. So same thing. Hope you are clear. Very simple. If you have this view, you get this kind of picture. That is a scale diagram, and this is the image what you get. Okay, right. You can see it can you can think about 3 legs. Okay, one is pulmonary artery, one is duct, one is the aorta. It can be transverse, it can be ascending, it can be descending, depending on your angulation. Okay. You can also view out sometimes, you know, if you keep doing properly, you can rule out TGA also. Overlapping. Okay. So just keeping sliding the probes, you can rule out many things. Okay. Right. See, very good pictures. Again, picked up from our RPA library. See, this is, you can see the constricted duct there on the top. You can see a patent duct on the right hand side lower, and you can see a big duct here. So if with the colors, you can see the duct, how patent it is in the second picture. In the first picture, you can see a constricted duct. And here you can see everything is blue. Okay. What is this? Everything is blue. Anybody you can guess? So Dr. Venkat was telling about right to left shunt, left to right shunt, about the Dopplers. Okay. What is this? The third one. Any idea? Sorry? There is right to left shunt more. Okay, you can get little bit of specules of red color, but usually if there is right to left, more of blue. And here what happens, you will miss the duct. So you have to put a Doppler there, okay, to find out there is a duct or not. So it is purely right to left shunting. Okay, so now you understood presence of duct using color Dopplers. If you use color Dopplers, you can find out is a patent duct or a constricted duct, or it can be right to left shunting. Okay, right. Thank you. So whatever I told, the second image just for your kind of clarity. So patent duct and a constricted duct. Okay, right. So as I told, you should have a proper Doppler gain and color gain. Doppler gain, because every machine, I've used two machine, which one is Vivideye and Mindray. So in Vivideye it goes till 96, right, meters per second, millimeters per second. The scaling, is it millimeters or Venkat? When you do scaling, what is the unit we get it? Meters per second, right? Yeah. So in Mindray we get only 90. So I've used Sonosite also, I forgot. So you should use it to the maximum. Okay. So the spillover will be less. And again, the gain should be controlled for specules. So two things, two controls, which you see in the machine. In the afternoon we'll show you. Okay. You don't get a PDA baby now. Definitely. Please see the images, learn about the equipment or the machine, and learn about the views, and learn how to hold the probes. Okay. Right. Next. Yeah. So now we have understood about a duct. We have understood about the presence of a duct. We have understood about a constricted duct. Now there is a patent duct. See the shunting. So when you keep a cursor in the duct, you get this upward waves. Okay. Upward waves is left to right shunt. This is one of the few places where you get upward waves, left to right shunt. Okay. Commonly seen is left to right shunt. Okay. Then comes bidirectional shunt, please. Yeah. See, you can see the red waves and the blue waves. Red waves is always pulmonary. Blue waves is always, red waves is always systemic. Blue waves is always pulmonary. So always systemic blood flow will be more. But early systole waves are more in pulmonary. Means pulmonary pressures are still below systemic pressures. Do you agree, everybody? There is a period in early systole where pulmonary pressures are more than systemic pressures. Okay, clear? That's why you get that overlapping map, gray scaling. So initially there is an early period of right to left shunt, followed by left to right. So the upward is, what is upward? Left to right. Initial dip is there, no, that is early systole, that is right to left. Okay. So usually you get this kind of picture when you see a duct, patent duct, when you put a cursor. Okay, just keep it in your mind. Okay. Next one, please. So again the pulmonary pressure is rising, and once it is rising, you can see that during the diastolic pulmonary pressure during systole exceeds systemic pressure, but again the diastolic pressures are subsystemic. So there you get a bidirectional shunt because the pulmonary pressures are increasing. Okay, clear? So you can see the downward wave there, everybody, but still more is left to right. Okay, to some extent right to left, because the pulmonary pressures are increasing. Next picture, please. So now at the end you can see the pulmonary pressures are more, which is suprasystemic, but you get a wave as downtrend. These waves are similar to what we saw for PPHN. Dr. Venkat was describing. You know, it's similar. So in PDA only we get this upper end wave. Okay, just in a very vague way I'm telling you. Okay, so this is very rare, having right to left shunt. Okay, you don't get it very often. Okay, right. Yeah, we'll go. Okay, this is again I took it. So again, so duct, patency, constricted, okay, over all this. Now next comes, how do we measure the pulmonary artery and the descending aorta flows? Because there are two vessels connected to the duct. So here there is a steel phenomena. If you look at the flow in the descending aorta, So where we have to put the cursor, it should be below the insertion of the duct in the descending aorta. If you put it up, you get wrong results. So if there is antegrade flow, means the blood is flowing through the descending aorta to the systemic circulation. There is no steal from the aorta to the pulmonary artery. So no steal. So what happens? See the first image. You can see the downward trend of the waves. Clear? Everybody clear? But if there is little bit of steal in the second, okay, that's called absent. Means the diastolic flow is not seen like the first one. You can see the diastolic flow. You can show. Yeah, that's the diastolic flow in the first one when there is no steal. The second image, when there is little bit of steal, down, that image. Yeah. You can't see the diastolic flow. You can only see the systolic peak. Everybody is clear? And the third one comes called retrograde. Very clear. You can see the diastolic flow above the line. Okay? So only in the diastole there will be variation in antegrade, absent, retrograde. This is called steal phenomena. Means more blood is again going back to the lungs through the duct. Everybody is clear? This is one more measurement you have to learn along with duct. Okay? Okay, I think Dr. Venkat and Dr. Nilesh spoke about QP, QS. It's 1, 1.3, 1.6 depending on the pulmonary blood flow. I'll skip this, okay? So I spoke about the duct. Again, LA aortic ratio, LV aortic ratio is something, a surrogate markers of a duct significance. I'm not talking about this. So if you put in M mode, you can, around the aortic valve, you can find this. So more than 1.4 is significant. So that will be in your advanced course. So I'll skip this. I spoke about steal phenomena. Yeah. Okay, so I was just going through the articles, what else I can add on to this talk, and I just got a Canadian article in 2015. Mackmer and Segal had graded the ducts, okay, category wise. So I'll just go through that. So E1 is there is no evidence of ductal flow on 2-dimensional or Doppler for confirmation. E2 is small non-significant duct of diameter of 1.5. There is restrictive continuous transductal flow, means minimal flow in the duct. And there is no signs of any heart chamber getting big, any heart chamber, not only left heart or whatever. So again, the end organ arterial diastolic flow is normal, means there is a very small duct, so not much difference for any organ. Okay, we'll go to E3. E3 is moderately hemodynamically significant ductus arteriosus. Again, so as I said before, 1.5 to 3 millimeter duct is significant according to them. So we have been taught like 1.6 to 2 is significant along with the other surrogate markers. More than 2 is very significant. If you go to RPI website and see the protocols, they are fantastic protocols. We always follow that. It's like a library for us. It can be formulary, it can be guidelines, anything. That is Royal Prince Alfred Hospital in Sydney. Okay, right. So this is E3. So again there is pulsatile transductal flow. Again there is a left heart volume is slightly more. There is a bit of loading happening. And here, decreased or absent diastolic flow in the superior mesenteric artery, middle cerebral artery, and renal artery. This is something we have to learn. Along with duct, we had one experience that there was a big duct, then suddenly we put our probe on the head. And there was a very irregular margin of the lateral ventricle. And there was some syndrome which it got fitted. So I forgot that syndrome. So it was taught by my teacher. Okay, having a big duct doesn't mean that only you should restrict your echoes to the heart. Put the probe onto your head. You can find many things. Or you can have systole diastole difference of RI. So there, then you can make out there's some problem with the baby's, blood flow in the brain also. So when there's a big duct, always put the probe on your head, on the baby's head. Okay. So again, E4 is more than 3, and lot of compromise in the circulation, severe left ventral heart volume. And again, there's reversal of end-diastolic flow in superior mesenteric artery, middle cerebral artery, renal artery. Again, these things you have to learn. And like I said, I'm just doing the same scans. Now, after you learn the cardiac, see, head is easy, then comes cardiac, then go for lungs. Lungs is also easy, then go for abdomen. So you keep learning more, because with these last 5 years, too much of learning about echoes, okay? Right. So this is one more I was talking about LI aortic ratio, which is a surrogate marker of a big duct. LI is left atrium, AO is aortic ratio. So you put a cursor in M mode near the aortic wall. How nicely you can get the M mode. You have to measure the diameters, aortic diameter and LI diameter. So if it is 1.4, it is very significant. Okay. So this is one thing you learn after the duct, left pulmonary artery, descending aorta still, and this one. Okay. So this is the same slide. See. Yeah. So again, left ventricular output measurement. So you have to keep a cursor near the aortic wall. One, you get the diameter, and then you look at the Dopplers. The machine will calculate. I mean, Dr. Venkat was explaining so beautifully about the formula. All the machines you can set. Left ventricular output, right ventricular output, SVC flows. Just calculate both, you'll get the measurement. So usually 200 mils per kg is the what you call output of left ventricle. Even right ventricle also is somewhere nearby. So both are equal. If you get 90 ml per kg per minute, I think, means there is some problem. There's big difference between pulmonary and systemic circulation, because so in the right ventricular output is only 90 ml. In the left ventricular output is 200 ml. So nearly 1:2, 2.5. So it is not a good sign. Okay. Yeah. So I told you about duct related to two vessels. One is aorta, steel phenomena. The other one is pulmonary artery. So in pulmonary artery, you can see the main pulmonary artery. You can see the diastolic turbulence. Can you see the diastolic turbulence? Systole, diastole. This is one way of finding out duct. They say in our slide, two ways. One is direct imaging. The other way is looking at the Dopplers in the main pulmonary artery or left pulmonary artery. If you find a turbulence in the diastole, it is confirmed. They say it is very simple and accurate also, the wordings. But nowadays we only look at the duct directly, because we have been well versed in that, because the machines have got better, the Dopplers have got better, the 2D has got better. Okay. So the same image in a more clarity. So increased diastolic flow, increased turbulence in the diastole. Okay. Right? Clear? Everybody clear? Right. So we will stop it here. What I would say is, measuring PDA is very important, very simple. It is the thing you have to learn first, then going to PPHN, etc., etc. It is easy. First you measure in 2D if it is very patent, but if it is restricted, use color Dopplers. It should be measured at the most restricted part, and it should be more towards the pulmonary end. And once you know there is a duct, go to the related vessels, that is descending aorta to look for steel, and left pulmonary artery to look for diastolic turbulence in left pulmonary artery. Okay. And then after that, you see if it is hemodynamically significant by looking at the surrogate markers like left atrium and aortic ratio and left ventricular aortic ratio. So like this, and also at the end you look at the head. Look at the head for RI index. It can be anterior cerebral artery or middle cerebral artery. So you will understand what's going on in the baby hemodynamically. So with this, we can meet in the afternoon for a practical session. We will show you how to hold the probe, how to look at the chambers, what are the views. Okay. And definitely we may not get a baby with PPHN or duct, but we will show you as much as possible. Thank you. Thank you. Thank you.
Thanks, Dr. Shekhar. Any question on PDA? PDA diagnosis, or it's a very complex topic. You try to make it very simple to make you understand. So, but if you start delving in the depth of PDA, then actually, there is, you just Google on a day, routine Googling on a day of PDA, you find some at least 10, 15 new research going on in PDA every day. This could be actually scoring of PDA, or could be, shunt significance, the treatment, various treatment methods and all. So it's still no clear answer is not the PDA. So it's quite an enigmatic topic, made quite simple by Dr. Shekhar. Okay, so there are no more questions. I think you can mark your doubts also. We'll be having a panel discussion. We can discuss on this, and we'll be having some hands-on session. We not really have a newborn PDA in the hands-on, but we'll learn more of a views to look at the PDA. You may not really have a ductus sitting in front of you to visualize, but we'll teach you that what are the views to be chosen to look at a PDA or a pulmonary hypertension or the atrial shunting. Those all can be discussed. We'll break now. We'll break for lunch, half an hour. We need to check again. Pass aa jaiye. Can come here. Pass aa jaiye. See, this panel discussion, we have made some questions what we thought is important for basic echo. But what is more important is we want you to all to speak out. Only one or two voice I could hear. This all hiding behind your mask. बोलना पड़ेगा आपको. Should talk. I am sure you should have some questions, burning questions, no? Unless you know everything, then fine, you are questionless. So, but learning doesn't end here. You need to have some doubts, some questions would be there. You just wake up your curious mind. So, and prepare some questions, think some questions. We'll start with our own question, what we made to begin with, but you should make it interactive. Let's start. Caller mic is there. You just speak like that. Make this. That hand mic is okay.
Hello. Hello.
Control is very dim only.
Between the earpieces, no? Similar to that. So you should know the anatomy, you should know, attend some kind of a seminar. Once you start using, you should know also about the knobology of the machine. So initially there is like I told, there is a learning curve. When you do initially, you won't understand anything, doesn't matter. The most important step in anything, in any learning you do, is the first step you take. That is, whenever you attend a seminar, tomorrow you go to your hospital, the first, if you have an echo machine, ensure you are keeping it on a baby's chest. That is the most important step. Otherwise, how much ever you learn, no use. It will just evaporate. That is the most important one. Practically, what we found was there are certain tips which we'll show you. When I started doing the echo, I had difficulty with certain images. So I don't know, the other experts can share their view. I had the easiest for me was the parasternal long axis. It makes sense for me because in the apex, somebody told me that you cut it like a capsicum, and I learned that. So it's a very simple thing. You keep it here parasternally and look towards the right shoulder. So I started doing from that, and in that only there are many views. So you can look up the pulmonary trunk, you can look down, then you can rotate it from the same view 90 degrees and you get the parasternal short axis. So it also helps you to build some confidence, because initially when you start doing suprasternal and all, you may not get anything. So practically for me that was easy. Also the subcostal views were easy. But like I told you, it's a long-term thing. There is a learning curve, so you have to invest your time, and as you go, keep attending seminars and you will learn over time. That's how I have learned. So basically get your hands on the baby and try these windows. The parasternal windows are easier.
So basically you're trying to say that you cannot learn actually from seeing through somebody's shoulders. You should hold the probe, not to worry, because all of us have gone through same phase. So there's partly self-learning, partly from workshops, partly from books and all those videos, but you can do that eventually. So it's not a difficult job, so trying to say. Thanks. So we'll move to second question. Next slide, please. Next slide. So this one is about actually when I chose to do a echo. So I think partly we know the answer, but we thought that Ankur can throw some more light on this. So to image a newborn heart, which probe is suitable? And there are some probe questions are there actually. We thought we'll cover all the probe questions first.
So as we have already discussed in the physics, there are different types of probes we work on. There is a linear probe, there is curvilinear probe, and there are the probes with the different frequencies, which is important, and that will be mentioned on the side of the probe. So on the sides of the probe, there will be always two things which will be mentioned. One is the pointer of the probe, which will help you to see that which direction you are seeing, when the same pointer direction will be there on your ultrasound machine also. And the second thing which will be mentioned on the ultrasound probe is the hertz. There will be some number, 2 to 6, 5 to 8, 5 to 8. All these hertz will be mentioned. As we have discussed early today, as a very basic thing, we want to use the high frequency probes for the neonatal scans, including the cardiac scan, because here we don't want great depth. We want the images to be brighter, clear, and high intensity, which will be better with our high frequency. So that is the reason we use the probes which have high frequency as compared to the probes which have having low frequency. We also use low frequency probes in the ultrasound and all, especially for the abdominal scan, because there the depth structures are there. Even in the neonate also we can use the probe which has low frequency, because for the abdominal scans you need a more wider depth. Same way in the pediatric patient, for the same echo you will be using slightly low frequency probes as compared to the high frequency probe which will be using in the neonatal scans, because you don't want such a great depth. You want the images to be crystal clear. So anything else, sir, we can?
So generally trying to say that higher frequency probes are suitable, as we were talking in the morning. So the frequency hertz, we all know that high frequency ventilators, how to convert the frequency into number of breaths per minute, same formula. So for every 1 hertz is equivalent to 60 BPM, breaths per minute. The same way here, actually every 1 hertz would release 60 pulses in every minute. We call as the pulse repetition frequency. The abbreviation is PRF. If you read all the routine ultrasound manuals, say as PRF. Is a pulse repetition frequency. What is the frequency of pulse repetition? How many pulses released in a minute? So 1 hertz means you get 60 pulses in a minute. So 10 hertz, 12 hertz means it close to 600 pulses comes in a minute. So the newborn typical probe would be what? 7 to 10, 7 to 12 hertz. That's the frequency what we use. Now one more question in relation to this, and talk about probe. I thought I'll ask Dr. Shekhar. Maybe all of us can contribute also. So all the probes mentioned the range of numbers you're trying to say, but the numbers don't have a single number, no, they have a range. 2 to 5, 5 to 8, 7 to 10. Why there is a range? So like say if I want one number, should I choose some number in the machine, or the machine does automatically? So that part needs some clarity. So we can throw some light on that.
Okay. So there are few probes with different frequencies. It depends on the company also. So as I said, I've used 3 companies. Some companies like Sonosite has got same probe for head and heart with frequency of 4 to 8. I think Vivida has got 2 different probes for head and heart, and also Mindray. Okay, Mindray has 1. So what we use in neonates is from 4 to 8, if I'm correct. And some of them will have from 4 to 12 also. So frequency is all set with the probes. Okay, and once you connect the probe to the machine, it automatically sets in. You don't have to change the frequencies. So coming back to your question, different companies will have different probes. In Vividai, we have, for head we have convex. For heart we have linear probes with different frequencies. For pediatrics it's a different frequency. For neonates it's 4 to 8. Coming to other companies like Mindray, Sonosite, it's the same machine, same probe used for head and heart both. Thank you.
Thanks, Dr. Shekhar. One more actually point I want to add to this. There's something called harmonic imaging is there. So harmonic imaging, what they know nowadays actually, that we recently got a Philips a model called Epic. It's a high-end machine we got. So we got really confused. That machine has a range of 4 to 12 hertz, very wide range, and say it has a cardiac probe. What exactly it does is, so in a machine you choose the part of examination or area of interest. My interest actually is head ultrasound, abdominal ultrasound, or actually cardiac ultrasound. I choose the area of interest. In the wide range, the machine, as Dr. Shekhar told, actually automatically it moves to higher or lower frequency. So if I choose cardiac ultrasound, It chooses 10 to 12 hertz, the higher range. If I choose head ultrasound, it goes to the lower range. So it modifies, that's called harmonic imaging. So automatically it actually adjusts the probe frequency in a wide range. So advantage, you don't need actually multiple probes. All the time you have to get many probes. So you have only one slot, you have to put one probe in that. Second probe doesn't get inside because only one slot. You have to remove it, put another probe in that. Those things all get sorted out. Actually, you have wide range probes, and you keep actually changing the examination wise the frequency changes.
Just adding on to Dr. Venkat. So most of the machines have two different probes for pediatric and neonates. Okay, so if you get a neonate probe, so the pediatric cardiologist wants a pediatric probe. So different probes, and also some machines have probes like neonatal probe is fixed, pediatric abdomen probe is fixed. Don't remove the probes often, lock and unlock. It's very expensive. Believe me, it is more than 2 lakhs, one probe. As an administrator, I know the pain. If you don't have warranty, you put it down, if you break it, it is 2 lakh rupees. Always you should have warranty for the machines, especially for the probes. Okay? Right.
Thank you. So we'll move on to the next question. Next actually I had to them is, before I start imaging the heart, so I'm ready, I have a right probe and everything is correct. No, I'm going to imaging the heart. So should I go and image directly, or I should do something with the machine to modify, to optimize setting? Setting has many components. You know, like say it could be a depth setting, it could be zoom setting, it could be gain setting. You know, so what are the settings commonly one should do? There can be many probes, many knobs and many advanced machines, but basic setting there are 2, 3 one has to modify to get actually a good imaging. What that should be? So that is one important thing. I'll ask two of them. One is Dr. Vinod and Dr. Kamal. Dr. Kamal can tell first.
Okay. So important thing is, whenever you have an image on the screen, the whatever is projected there, it should at least cover 3/4 of that screen. Otherwise, it will look very small or it will look very zoomed up. आपके साथ होता होगा कि very small, छोटा सा आ रहा है, and then it comes slightly bigger one. So it should cover 3/4 of that screen. For that, you have to adjust the depth. Depth is basically, as already explained, the depth. If you increase too much of depth, increase means आप बहुत ज़्यादा बड़ा करने की कोशिश करते हो, you have all the pixels spread out and you don't see anything. Very small, you are not able to find that lesion. So 3/4 of the screen, set the depth over there. Same thing when you set up, I was telling the gain. Gain is like a color gain. So whenever you set the, and the gain of the 2D machine, both the things. So it should not look too bright. आपको लगता है दिख नहीं रहा, इसको white और white करते रहते हैं. You keep on increasing the gain. Or sometimes you will see बिल्कुल ही black, you are not able to set the gain. So the two important things, the gain and the depth has to be modified according to that, whatever you are seeing. So if you are seeing like a calcium deposit over there, so you want more of a black and you are seeing a calcium deposit. Just we see a fetal echo and there is a myocardium thickened and echogenic cardiac foci is there. So a calcium deposit there, something of that sort. You are seeing a mitral valve and you are seeing a thickened mitral valve. You want that it should be seen. So more of a blacker one. You are not able to see the pathology, more of white one. So it is an optimized gain. So there is a button on the machine that shows auto gain. So it adjusts according to that, whatever you are imaging. Does that answer, sir?
Yeah. So Dr. Ankur, you want to add something to this? Settings actually, like say gain, depth.
This is only very important. So as we have discussed in the morning also, I showed the time gain compensation. So the most important thing is the gain, focus and depth. 3 things we can see. These all things we have discussed in the morning. Focus, again, is that on the whole parameter of the ultrasound machine, you can set a area where you want to focus. When you set any area of the focus, the images, the signals going from the transducer will be getting convergent over there to get you the maximum image reflecting from that tissue, what you want. On the side scale of the ultrasound machine, there is a focus, there is an arrow where you can say that I want to focus any tissue you have seen, you want to see the pathology, anything there, you want to see the things over there, you can focus. So this is the area where the maximum concentration of the waves will happen and you will get the bright images of that area. Another thing is there again, what we have discussed in the morning, the images from below that structure will not be again visible, means you will lose the depth, but you will gain at that focus where you have put maximum area of the bringing back the images and seeing it more clearly will be there. So that facility is there on the machine to adjust. When we talk about focus, we have to also talk about depth. Some structures are very deep, so you want to, there will be a certain window that my images are going up to 10 mm inside, 15 mm inside, and we are seeing the structures over there. But if you want to see the more depth structure, because your any structure is located posteriorly, you want to go inside and see, then you will have to increase the depth again on the machine, which will be by a knob available on the machine or by the arrow plus minus. So you will do that, automatically your depth will increase. As your depth increase, now you can see the deep structure inside where the wavelength will be going again, the as we discussed in the morning, shorter wave, longer wavelengths, and bring you back the images. Again, those images from the deeper structure will not be so bright, it will be less, but we have to get the depth. So the depth and focus is the two important
So
things.
summarize basically that depth is one important thing, gain is another important thing, and depth and focus, actually they are interrelated to each other.
Yes.
So, and what is trying to say that you need to have a sector.
Yeah.
The sector should be full with the structure what you want to see.
Correct. Otherwise you will
If
not be able to
my
visualize.
interest actually is like say iota diameter, so you should try to actually depth modification such a way that the iota actually is seen in the focus and the deeper things are not actually much focused. So you can modify the focus and depth, you can modify, there are knobs out there. In the workstation you can tell what exactly you should do. So depth, focus, gain. Three important things you should actually modify, control to get a good image. How one should do that? We should learn on the machine, but we'll do in the workstations, right? Thank you.
We also make a small mistake. Instead of zooming out, we use the depth, thinking that we can zoom out. So it's wrong. Zooming is different, depth is different.
I think zoom actually is more like cosmetic thing, no? Cosmetically, you want to see something closer. It doesn't do anything to the pixel, to the resolution. In fact, make it less clear also. If you zoom it actually, the pixels the same. It's broken actually, and then all becomes scattered here and there. You may look it less clear, but you want to see it more closer, then you can use zoom. I don't use zoom. I haven't actually used. Okay, so let me move on to the next question. I want to ask Dr. Sarjan. Dr. Sarjan is virtual, so I guess he's able to see us, not able to hear. I can ask him. Okay, so when I start visualizing the heart in a particular view, I often find it difficult to get a brighter image. The image also looks smaller than I visualized. How to rectify this problem? So the answer is in the first question. So can somebody answer this? Dr. Sarjan will join now. Can somebody answer this? One is I am not able to see actually. One is I am able to see. I want to get a brighter image. What I should do? And the structure which I want to see looks very small. What I should do? Any volunteer? How can we get a brighter image? Which gain? There are many gains in that, no? 2D gain is one. Color gain is one. Doppler gain is one. We'll tell you in the machine what those gains are. But the common gain which we talked till now is 2D gain. 2D echo in a 2D mode, 2 gain is 2D gain. So the gain has to be increased to get a brighter image. But increasing beyond a point would not really help. Okay, second, if something is looking very small, what you will do? You modify the depth actually so that you start ignoring the deeper structures and you make it less deep. It depends on what you want to see. Something lying superficial, I make the whole thing less deep so that I don't see something beyond that. I want to see kidneys, for example. I make it more deep. So kidney becomes the focus of organ to see. The sergeant is joined. Yeah, he is there. We could see him. Dr. Sarjan, are we audible? Dr. Sarjan, am I audible? Yeah, Dr. Nilesh.
Okay, am I audible on? Am I audible on the through the mic?
I think we choose the old method, no? We'll actually log in from here, the phone, and we'll put in the mic.
I'm not
working, Sergeant.
Okay, so whenever we throw ultrasound beam into any tissue, the ultrasound waves either get distracted or absorbed. That leads to loss of signal. So as we see from the probe, as the waves are getting down and down, the deeper structures are getting less and less visible on the on the screen. So the structures which are close to the screen are very bright, but structures deep down they are not as bright as they are closer to the structure, closer to the chest wall. So basically, this is attenuation. So what is the way out? If you have this type of a problem, then will not be able to see the structures better. To overcome that, we have two methods. One is 2D gain. We can adjust 2D gain, and which is you can see on the right hand side of the slide. You can see three knobs on the say this is the yeah. So there are three knobs which you can see on the left hand side of the panel of the. So there are two pictures in this one on the right side. The picture which is right side, you can see three knobs on the left side of this picture, and they are the ones who with whom we can adjust 2D gain, and the similar knobs are available in each machine. This is on the microwave tonocyte. So once we adjust 2D gain, it increases the brightness of all the structures from top to bottom. The other option is time gain compensation. So on the left hand slide, the other image on the left hand side, you can see a staircase like thing. These are the knobs which adjust time gain compensation. And what do we mean by 2D gain? 2D gain increases the brightness symmetrically from top to bottom, but the time gain compensation increases the brightness in a differential manner as we set on the machine. So you can see that the brightness of there are some 7, 8 knobs which are there, which you can see on the left side. So the top knob is very close to the zero, and the which is on the left hand side, and the bottommost knob is on the right hand side. So which means that I have asked machine to give maximum gain at the bottom and minimum gain at the top. So which it does mean that brightness is increased differentially. So next slide, please. Next slide, please.
Sergeant, you can change.
Okay, actually I'm not able to see next slide.
Okay. यहाँ से करो ना, आप करो.
Are you able to see there is a lag? Are you able to see the next slide in which effect of gain is there?
The next one.
Yeah. So this slide shows the effect of gain, 2D gain. If I increase this, then there are two images. The previous one. Okay. So we can see there are two images on this panel. In the left image shows that the effect of attenuation, deeper pictures are not visible. But when I increase the gain to the right slide shows the effect of 2D gain. We can see the structures have come now more bright. Next slide, please. Yeah. So if we adjust the time gain compensation, the structures are made brighter symmetrically from top to bottom. So we have given minimum gain at the top and maximum at the bottom, so that the gain is optimized. Differentially, gain is differential. The images which are attenuated, the structures of this image which are attenuated maximally, we give maximum gain to them so that the structures appear equally bright from top to bottom. So this is the benefit of time gain compensation. So if we have if I'm able to see the image very clearly, I can use 2D gain or time gain compensation that will make the image appear bright on the screen.
Okay, thanks a lot. I hope they all got the point. So we'll get back to you. Okay, yeah. I'll cut the phone now. I'll get back to you after a while. Yeah, thank you. So basically the message is that brightness is same as amplitude. Gain, brightness and amplitude. So if you have a sound wave, it will have a peak and a trough. So taller the peak or lower the trough, because it goes like a sine wave, no? Ultrasound travels like a sine wave. Taller the peak or lower the trough, higher the amplitude. Higher the amplitude, higher the brightness. How to increase the brightness or amplitude? By increase the gain button. 2D gain, you increase it, it will increase. Using time gain compensation, instead of increasing actually throughout the screen, you can time the gain compensation. It means that actually certain fields are actually get the more gain or more focus, more reflection, more amplitude, and certain fields actually are under suppressed. That's the idea of TGC, right? So we'll move on to the next question. So next question to Dr. Kamal. When do I choose a 2D mode and when should I choose an M mode? That's a very important doubt. Our residents frequently asking actually when should I choose 2D and when should I choose M mode? So Dr. Kamal can answer this.
I think I thought it was that simple. We start with always a 2D mode, that is a B mode. So whenever you see the structure as an anatomy, you always see the B mode, use a B mode. But if you want to see the motion of a structure, like if you are seeing an IVC, and you want to see the IVC collapsibility index, the IVC is moving like this. So we'll put a M mode over there. You want to see a mitral valve moving, you will see the M mode over there. You want to see the LA ratio, the LA and the ratio, they are moving. So you will put a M mode over there. So wherever there is a motion, it has to be the M mode. Whenever you start with the basic, that is a 2D mode. So you see the anatomy first, you see what is happening. Is there any defect or not? You don't put a M mode to see a defect. You see in the 2D mode. Then you can go on to the color mode and all those things. But the question is focused that 2D is to see the anatomy and M mode is to see the motion mode. That was clear even in the morning lecture.
So one more thing actually, if you want to make some measurements, so then you choose M mode.
Yeah, ejection fraction, you want to see ejection fraction.
So wherever possible.
Yeah.
Wherever possible, M mode makes it more accurate. 2D you can do measurements, but M mode makes it more accurate. So measurement, M mode, where there is a event happening over some time, you want to capture that on a horizontal scale, like LV contracting, relaxing, happening over some time. Contraction happens earlier, then relaxation happens. I am visualizing it, but I want to actually put that on time scale. So I can see contraction, relaxation on a time scale. What is the advantage? I can compare all the events. I can choose a good event, good location, and make good measurement. So motion mode has got many advantages. So measurement, choose motion mode, otherwise 2D mode, right?
To be more accurate, we can see a thickened interventricular septum in a gestational diabetes baby. We can use M mode to measure properly.
So next question is to Dr. Shekhar again. Yeah, it's your question. So why don't I see the correct vertically placed heart in apical 4-chamber view many a times? How should I manipulate the probe to get the image correct? So Dr. Nilesh had partly said, because to a novice, to a beginner, actually sometimes you find difficulty in certain views. Like say, I might find apical difficult, you might find short axis difficult, and keep training and you get that. But one mode, actually, the reason I put this is, many times our residents, we tell them actually you should have the heart straight so that you don't have any foreshortening. We'll talk what foreshortening is. So, and then make the measurements. They keep juggling around all the time. Actually, in a 4-chamber view, the heart looks like this only. It doesn't become straight. So anything actually we can do, some tips and practice, so we all can share, they can learn from that. That's the idea.
So typically, when you keep the at the apex, when you keep the probe even properly, for usually for newborns, I think for the pediatric kids, you get it like a proper heart. Ideally, you should get a heart that is standing up. It looks like an apple. The septum should be straight, so that in the next step, when you are going to do the kind of the measurement, when you are doing the aortic flow, when you're doing the cardiac output measurement, what is the basis of it? Why do we want it straight? So one thing is we have to get to know about the heart. We have to kind of do the eyeballing, look at all the chambers and all. So it's sometimes difficult when it is kind of lying down on one side. So there are some tips. These are from my practical this thing. Maybe Dr. Venkat can add on. So whenever we do for preterms, usually when we do the apical view, you see like the heart lying on one side. So you have to get it up like this with the septum in the center. So it's kind of, so usually what we do is we keep the probe, and what I do is I try to angle it a little this way. So the probe, I don't know what this thing is there. So we usually angle it a little way, so or towards the right side, and then the heart comes up. So it's more of a, probably we can show you during the practical session. So is there anything in particular you were
There is
asking?
a way to manipulate. It means that in a 4-chamber view or any other view, there is a way to manipulate. Again, actually, one important actually drop, you rightly said actually, because you manipulate, what I do normally actually, I move more laterally and try to make it actually more aligned towards 2 o'clock position. You hold in a 3 o'clock position, you don't get, make it 2 o'clock position. It means that cursor is toward 2 o'clock position, and go more laterally. As I go more laterally, I can see the heart is getting more and more straight. So which we can see there in the demo. But the message actually is that, so every human heart, newborn's heart, or every individual heart actually would not be alike, all will be different. So you may have to manipulate, modify the position, and learn actually certain nuances over the time to get a good image. Important is you should see the image as it has to be seen to make a measurement. That is very important. So
Sir, just
next question, yeah.
one thing to add over here.
Yeah,
Just
please, please.
once you start doing an echo, first you keep a probe over here, like this apical, this subcostal, this parasternal, like this. But once you start doing it, you start it like that, but after that you start seeing the machine screen. Baby ko dekhna chhod dete hain uske baad, because you just manipulate the probe and you see, this is okay. You don't see that is it the right position or not.
This is a very important point actually. Automatically you will end up seeing the machine, baby. You look at the machine, so your hand-eye coordination will automatically come with practice. So what normally we do, we see only when we keep the probe there, apical. Then we don't see baby. We look at the machine and we keep manipulating, and your manipulations actually become finer and very subtle, because you cannot move a big movement and you lose the heart. A little bit movements, subtle movements to get the heart appropriately. That's very important. Right. Good. So the another common question actually which Dr. Nilesh should answer actually about the color flow Doppler, color flow imaging. Some machines say CFI, some say CD. It's variably managed. So color flow imaging is another important thing. You have a color gain, color scale. So you can maybe try to address both the questions 9 and 10 actually, that when do you use color flow imaging, and you have a scale appearing there. So how do you manipulate that scale a little bit, because we can have more on the workstation.
So color imaging is basically like we have to do a few things. So one of the things in the armamentarium, whatever we are doing to assess or to get to know about the blood flow, one is M mode again, then pulse wave, continuous wave, and one of them is the color. Some of these machines have it written as CFM, the color. So basically they overlay the color on, you can think of it like on a pulse wave Doppler, you overlay color on it. Both of these are very similar, the color and the pulse wave Doppler. So you have to know there is something called the Nyquist scale. This is called the Nyquist scale. You will see a scale on the right side when you put the color Doppler. So there are few things. When a color it's coming towards you, it is blue. It is red. Whenever you are looking at towards the probe, when blood is flowing, it is red, and away from the probe, the color will be blue. So these are basic things. So you can look at the flow. If the flow is uniformly blue or kind of uniformly red, if you have set a proper frequency, it may indicate laminar flow. One of the things is you can identify turbulent flow. It is just like pulse wave Doppler. There is a aliasing phenomenon here. So if what happens is, if there is a turbulent flow, you may see a green color or a different green and yellow colors there. Where do you use it? So you can use it in multiple places. In the heart, if you are looking at it, inside the heart, you can visualize the shunts. So Dr. Kamal had shown the interatrial shunts. So you can look at the direction if you carefully look at it. You can look at the PDA. You can also look at shunts like VSD. You can look at the valves. So aortic stenosis, you will have turbulence, and you can see turbulent colors and in the color Doppler. You can also look at the vessels. So you can look at the veins and see the flow. You can look at aorta. So basically, how do we adjust the color scale? So it is something related to what we call the PRF, the pulse repetition frequency. So whenever velocity is high, like suppose you are visualizing kind of a TR jet or a small VSD jet, you have to set it on a higher side. I'm just telling a basic kind of a ground this thing. Whenever velocity is very low, now you are looking at celiac or superior mesenteric, or you are looking at the anterior cerebral arteries, renal arteries and all that, you set the velocities extremely low. So the velocities you have a meter per second, you have it's called the Nyquist scale. So you have a scale there. So it is usually around, some machines give it as 0.78 or this thing, some of them give it as 78. So basically you go to numbers like 10 or 20 for the slower vessels. For pulmonary, suppose you are visualizing the anterior cerebral, middle cerebral and the celiac mesenteric, you go to 10 to 20. Low flows, because the flow is very low, so you need a less pulse repetition frequency. When you are looking at pulmonary vessels, the flow is there, but it is not as much as the aorta or the fast shunts. So you can keep the color scale at around something like 50 to 60 or so. And when you are looking at a PDA and all, usually we keep around 70 to 80. Around that is usual.
Sorry, I'm cutting short because we're running short of time. So basically we have a scale. So the scale you should modify depending on the structure you're visualizing. If it is high velocity, modify accordingly. Low velocity, modify accordingly to prevent aliasing. So now I'll skip the 10th question which we addressed already. The 11th one, I want actually each one of you to tell actually one thing which you should not comment about in a view. Like certain views, you cannot really comment about any structure. Otherwise, you will actually end up in a wrong conclusion. So do we have anything like subcostal, I should not do some measurements, or should not do something, or should not comment about some chamber? Similarly, actually, apical, something is there. Long axis parasternal, something is not good for that. But we should also know exactly that which view is not good for certain structure. So Dr. Ankur can tell that what we should not comment about or look at
subcostal,
in a
sir,
subcostal.
I feel that we should not be commenting about the aortic any measurements or aortic thing, because other things we will be viewing in the subcostal and apical. They are very near to each other. In apical we will be having a complete 4-chamber view, and we are getting all the details. We are getting all the channels and any interventricular defects or interarterial defects. And when we comment on the subcostal view, we are having more aligned with our veins, superior vena cava, inferior vena cava draining there, and the chambers of the right ventricle and right atrium.
Yeah, that's right. But anything you
aorta, I feel
don't look for this in subcostal is aorta measurements. Don't look for in subcostal, right? Correct. So anything in the apical, pulmonary veins, you should not comment actually about the apical. Anything actually, Dr. Sarjan, I don't know, joining and taking his time. Any long axis parasternal that Kamal, you want to say that anything you should not comment about in a plaques view?
I think in the plaques view you have a heart which is cut like he was saying, capsicum jaise cut kar de. So that was a good example actually. So it's a long. I don't want to see a PD in that view. I want to see the LA ratio in that view. That is the most important, or the ejection fraction in that view.
LV output in that, because we can look
Yeah,
at the
LV
aortic wall. We should not look.
What we should look is LA ratio and the contractility.
Contractilities. First thing to learn is contractility with that view. Just keep the probe here. You can see the heart contracting. So then you can be confident about inotropes, what you should use, what you should not use.
Because at least the long axis parasternal view, I personally don't look at actually pulmonary artery measurements in that unless you modify it. That is one. Subcostal view, we keep teaching, and all of us, all our seniors who got trained, actually they all tell us never comment about ventricles in subcostal view, because 90% time you can find the ventricles, that too right ventricle looking foreshortened, looks very small, and there are many senior residents of DM doing senior residents. They say that the baby has, RV is not well developed, RV is hyplastic, HRHS. You do apical view, you find a normal right ventricle. So never comment about ventricle in subcostal view. The reason actually ventricles, right ventricle is very anteriorly placed. Subcostal, the ultrasound beam would not intersect the ventricle very well, right ventricle. It only partly cut the right ventricle. Whatever it intersects, that's what you can see. You cannot see the rest and all. You will decide that RV is not well developed. Similarly, in apical chamber, pulmonary veins is one. We never comment about atrial septal defects in apical 4-chamber view, because atrial septum actually comes from behind to forward, and apical view, the ultrasound beam never ever cuts the atrial septum completely. 90% newborns would have ASD. If you look at the septum in the apical view. So never comment about septum in apical view. Atrial septum, atria, the right view is subcostal view. Ventricle, the right view is apical view. That's the take home from my side actually. So rest all actually are valid points. You can move to the next one. Next. Okay, so this one I think we can discuss. Dr. Sajan, maybe very briefly on point number 12. Can I use parameters like IVC size and collapsibility if you want to address verbally? Okay, so I think that question actually is more like a practical thing we can show in the workstation, how to look at the IVC, how to look at the collapsibility. So what precautions should I take when intend to measure LV diastolic function, mitral inflow parameters, which we can discuss in the station again. The next question, next slide please. This we discussed already. Question number 14. In which situations the presence or absence of a TR jet carry less significance? I told in my talk that if you have a RV dysfunction, or there is actually an inherent TR, those conditions can lead to a erroneous measurement of TR jet. You may find a TR jet when it's supposed not to be there, or a TR jet would not be there, supposed to be there. Like there is a high pulmonary artery pressure is there, but RV dysfunction is there, you may not have a TR jet. So those things are actually TR jet fallacies are there. That is one. Okay, this one I think Dr. Shekhar told in his talk. Question number 15, any fast screening echo parameter? He showed the pulmonary artery turbulence in the diastole. He showed one slide, and very beautiful slide he showed that main pulmonary artery, I'm sorry, I'm just answering your question to finish up because you told already. So main pulmonary artery, the diastole, so very easy. Put the probe, look at the main pulmonary artery. The diastole area should be empty because you have valve there. During diastole, no blood flows in the main pulmonary artery near the valve area. But if there is a turbulence, the only reason could be a left to right shunt, could be a PDA or a aortopulmonary window. There is no other reason. Only these two could be there. So there is a faster way to pick up PDAs there. Then you can do all the measurements. If that area actually is totally empty, nothing is there, then screening for PDA also is not worthwhile. This one I think Shekhar can tell. You said actually partly, that color Doppler. So color Doppler has got a drawback using color Doppler, because you may end up actually measuring the diameter actually larger than what actually it is, because it spills out. So always try to measure the color, the diameter in a 2D Doppler. Color is not a preferable mode. That's what we're trying to say in this. So the last one, you want to add something or will finish off? 18th, 17th I'm skipping. Okay. Because normally I use PW and then CW. That's my order. So
If you want to look at the pulmonary hypertension, just use continuous wave. That's the only place I use continuous wave. I know I may differ from others, but continuous wave, PPH. When you're measuring PPH.
Any questions from your side? No. Any questions from?
In each case, all the sites, all the position you discuss,
every time we have to go by the protocol. Yeah. Whenever you are doing an echo for the first time, you have to start with this view. Not I'm saying subcostal, but is the situs okay or not? And then you go to the apical, then go back and then come back here, subcostal. Subcostal, just look for the situs and then the apical, because subcostal view is always disturbing to the babies. So usko end में रखते हैं हम. CW is continuous wave Doppler sir. तब use करते हैं जब आपकी velocity ज़्यादा है. यहाँ पे आपको regurgitant jet आ रहा है, जैसे TR आ रहा है. So it is more than 2 meter per second. Otherwise जो word बार-बार aliasing use कर रहे हैं, aliasing हो जाएगी, तो वो नीचे जाके ऊपर आ जाता है वापस. Like this is line आपने Doppler डाला, आपने नीचे को गया उसका wave form. वो नीचे पूरा आपको peak नहीं दिखेगा. M mode में नहीं सर, M mode is motion mode. आपने जब velocity चेक करनी है वो M mode नहीं, M mode is motion. आपकी velocity, आप move कर रहे हो मेरे को पता लगेगा, आपकी velocity कितनी है वो मुझे उसमें पता लगेगा, Doppler में. वो Doppler में पता लगेगा. CW डाल के फिर आपको जब आप जैसे CW प्रेस करेंगे, अपडेट या उस पर प्रेस करेंगे Doppler, तो आपका वो velocity आना शुरू हो जाएगा, ग्राफ बनना शुरू हो जाएगा. उसको जब आप फ्रीज करेंगे उसमें आप मेजर कर लेंगे. Any other question?